Good evening, everyone. I'm Dr. Monica Darji, Head of Scientific Marketing at Unipath Specialty Laboratories and UNIGENOME, and it's my absolute privilege to welcome you all to the second episode of the clinical webinar series, Decoding Genomics for the Unborn. This academic initiative is proudly brought to you by the Fetal Medicine, Perinatology, and Genomics Committee of OGSH in association with the Obstetrics and Gynaecologist Society of Hyderabad and powered by Unipath Diagnostics. Before we start our PowerPoint session, let me brief you through the housekeeping rules. Everybody except for the presenters, faculties, and the moderator will be on mute to ensure uninterrupted session. However, you can ask questions anytime during the session using the chat box or the Q&A panel. There will be live interactions planned for you at the end during the Q&A segment. So there you can raise your hand and we will unmute you so that you can ask your question and get the answer. Post-webinar access will be given to you in the form of a recording on YouTube, which you'll be receiving on your registered email ID. Moving on, today's topic is very interesting. It's from preconception to preimplantation, the transformative role of genomics in the reproductive outcomes. To put it simply, we are moving beyond empirical guesswork to explore how early genomic insights can break the devastating cycle of recurrent pregnancy loss and unexplained infertility. Before we dive into the clinical cases, I want to express my sincere gratitude to every clinician who's joining us this evening. Your participation is what truly makes this session enriching and learning. Now, moving on to our esteemed guest of honor. It is our privilege to introduce the guest of honor, a true stalwart in the field of obstetrics and gynecology, Professor S. Shantha Kumari ma'am. The name synonymous with leadership, clinical excellence, and academic brilliance. She has served as a treasurer of FIGO, as an ex-president of FOGSI, and an immediate past president of OGSH. This academic initiative is possible due to her guidance and support. My privilege to introduce Dr. L. Jayanti Reddy ma'am, the dynamic president of OGSH and director of JJ Hospital, Hyderabad. She brings decades of clinical experience, teaching experience, and patient-centric care. A passionate academician and recipient of the Young FOGSI South India Oration Award, Madam continues to drive collaborative excellence in women's health. Madam, we would like to hear a few words from you.
Thank you, Ma. Thank you for your introduction. It gives me great pleasure to be here on this platform. And a good evening to all of you and to all the people who have registered for this webinar. It is very heartening to see the number of people that have registered. And as a continuum of what we were doing regarding the genetics, the very important thing is while we were students also, and now for us, it is something like an enigma. So when we go into the genetics, even when students, we said, okay, this chapter we will read later. But our main aim and of Shaguns and to you people is that we have to simplify this particular topic in such a way that all the clinicians will be able to understand what is happening, what is there, and what is that you need to know, and how to use it in your clinical practice. So in the first webinar, we were able to cover a lot of ground regarding the recurrent pregnancy loss. And today we go one step ahead where we will try and see what are the genetic factors that are causing the male and the female infertility. In fact, we do the karyotyping for the husband and the wife, and then when we get the report, we need to understand that report. And sometimes the report says this is a normal variant, and then we need to understand that this genetic jargon. So it is very important, and I'm sure today our learned speakers will be able to throw light upon this aspect. And not only this, the patient will come with recurrent pregnancy loss, and so many cases may be having just infertility. And what is the role of the genomics in this infertility? What do we know and understand? What is this PGD that we need to understand? When I just started my practice about 30 years ago, I used to make a note of all the cases that had recurrent pregnancy loss, and we used to do the semen analysis, just recurrent pregnancy loss and the semen analysis. And invariably we would find not only that of the knee, but also when you look at the morphology and of the patient, that is the husband's face, we would find that there is less amount of facial hair. Simple clinical evidence also would throw us a light. Something is there in the genomics or the genetics of this. So one aspect is this. The second very important aspect is how much is the chance of these genomic changes going to the progeny and to the next. I am sure today all these questions will be answered by our esteemed speakers. I welcome you all to this webinar, and I'm sure you're going to emerge with a lot of knowledge regarding this tough topic. Thank you for giving me this opportunity.
Thank you, ma'am. Thank you for your blessings and kind words. Moving on, it's my pleasure to introduce the Secretary of OGSH, Dr. Manjula Rao, ma'am, Senior Consultant and Head of the Department at Durgabai Deshmukh Hospital. She is a distinguished clinician and an academician with strong professional presence. She has been a key contributor to the FOGSI ICOG Good Clinical Practice Recommendations on antenatal care, which is widely followed across the country. With multiple publications to her credit, her expertise spans maternal fetal medicine, antenatal care, and reproductive genomics. Madam, inviting you to say a few words on this webinar.
Yeah. Thank you so much for those kind words and the description that you gave. It was so nice to hear like that, but thank you so much. And good evening to everyone. Am I clear? Is my audio clear? Or should I switch off my video? Is my voice breaking?
No, it's clear. It's clear.
Hello. It's clear. Okay. So I think today, without wasting too much of time, I think we should just head straight forward. I congratulate Dr. Shagun Agarwal. I think she's if you have seen her, been in the last webinar, it was a very brilliant webinar, and I expect this also to be as brilliant as that. My congratulations to you, Dr. Shagun. You curate all the topics so well, and it's so useful for us as a general gynecologist. And let's get started. So I think everybody's waiting for this.
Thank you. Monica? You're muted, I think.
Right, ma'am, I was on mute. I'm so sorry. Yeah. Thank you so much, Manjula ma'am, for your kind words. Moving on, I have the honor of introducing the architect of this series, Dr. Shagun Agarwal. She's a professor of medical genetics at NIMS and an adjunct scientist at CDFD. With a rare combination of MD in obstetrics and gynecology and DM in medical genetics, she bridges the critical gap between reproductive medicine and advanced genomics, guiding clinicians through today's most complex diagnostic decisions. With over 80 plus research publications, multiple book chapters, contributions to novel gene discoveries, her academic impact is truly exceptional. An academic contributor to global consortia and a leader across national platforms, she's also shaping the next generation through clinical genetics fellowships. Madam, thank you for leading this initiative. Over to you for a few words.
Thank you, Monica, and thank you, everybody. Thanks to Unipath for, hosting this series, and to Dr. Jayanti ma'am, to Dr. Manjula for supporting our committee in creating this series of webinars. So as Jayanti madam said, so last webinar we saw how recurrent pregnancy loss, what kind of genetic testing is relevant, and how does it actually help in clinical management. So the purpose of all these webinar series is to make sure that practicing gynecologist is able to use genetics in day-to-day practice, and it should not appear like, Greek and Latin to the gynecologist that immediately, it's like, as ma'am was saying, that we never read the chapter of genetics when we are doing our MBBS MD. So we hope through this webinar series, through simple case scenarios, to kind of decode this aspect so that it becomes clinically usable genetics. Okay, so that's the whole purpose of this whole series. And today we are going to talk with respect to infertility. So I think without further ado, let's just move on with the academic sessions. So we'll go on to the first session then. Monica, just introduce the chairperson and then we'll move forward.
Sure. Thank you, ma'am. Session 1, we are going to focus on a complex case, a woman with ovarian insufficiency. And to guide us through this session, I'm delighted to welcome our expert faculty, Dr. Lakshmi. She's a senior consultant fertility specialist and medical director at Art Fertility Clinics, Hyderabad. With over 15 years of experience and more than 5,000 ART cycles, she's leading authority in managing poor ovarian reserves, recurrent implantation failures, and cost-effective IVF. A respected academician and a former secretary of OGSH, she's been recognized with prestigious honors, including the ISAR Young Talent Award and Dhira FOGSI Award. We're truly privileged to have her share her insights today along with Dr. Shagun Agarwal ma'am. Now, presenting the clinical case for this session is Dr. Valli S., medical genetics resident at the Nizam Institute of Medical Sciences. Dr. Valli, the floor is all yours for the first session. Thank you.
Thank you, ma'am.
Please unshare the slides, Monica.
Ma'am, is the slide visible now?
Yes, please, let's go ahead.
Yes, ma'am. Good evening, everyone. I'll be presenting the first case scenario for today. So, 36-year-old female patient presented to the genetic clinic. She's been married for 6 years and gives history of primary subfertility of 5 years duration. There's history of one biochemical pregnancy, and after that, she was never able to spontaneously conceive. Attained menarche at 14 years of age with history of oligomenorrhea for the last 2 to 3 years. No known comorbidities in either partner, no other relevant family history or known genetic disorders in couple's family. So this is the family pedigree of the couple.
Dr. Valli, please explain this pedigree briefly, because I'm sure many in the audience will not be familiar with this.
Yes, ma'am. So this is just the basic pedigree symbols, which I'll be just briefly discussing. So square for a male individual, circle for female, and a diamond for sex not specified or a difference of sex development. Multiple individuals, usually when the age is not known or unknown number of individuals and family members, we just put the symbol and the number inside. And same, if the number is also not known and the sex is also not known of the family members, we just put a diamond and N inside. Relationship status is shown by a horizontal line. That's a single line that is non-consanguineity, and 2 horizontal lines will denote consanguinity. If there is a slash across the horizontal line, then the couple is, they're not together, they divorce or separated. Abortion, a plain triangle if without a line across. If there is a line across, that is termination of an otherwise ongoing pregnancy, which can be due to a personal reason or due to some medical issue. And multiple gestation, the common point branching, with the line in between the 2 branching lines would represent a monozygotic twin pregnancy, and without the in between, if there is no line, that is dizygotic twin. And possible reproductive scenarios, which we can represent like a circle with an S inside, which is used to denote surrogacy, and D written inside. Male, for a male, it is square with D inside, and for female, it is a circle with D inside for a sperm donor and ovum donor, respectively. Adoption is usually shown inside the brackets with a dashed line, with a dotted line, and that is for adoption, adopted in. And for adopted out, it is like a continuous line. And no children by choice, a single horizontal line with in a couple. And for infertility, 2 horizontal lines. And for a carrier female, for especially excellent conditions, circle with a dot inside would represent carrier status of female. So moving on, back to the pedigree of this couple. So here, this is the consultant couple, 38-year-old male. The male partner is 38-year-old and the female partner is 36-year-old, and they have come for the consultation. And they've been married for 6 years with a history of primary infertility for the first 3 years, and then one possible biochemical pregnancy, after which they've been not able to conceive, which means again infertility for another 2 years. And there's no relevant or significant family history in either partner's family. Like the female partner has one younger sibling, one younger sister, and one younger brother, and the male partner has one younger brother. And there is no significant family history otherwise related to this couple's history. And previously, some workup has been done for this couple in view of primary infertility, and karyotyping has been done outside with the usual 20 metaphases, which means 20 cells have been analyzed. And it shows normal karyotype for husband 46XY, and for wife it is 46XX. The antiphospholipid antibody workup done in view of one biochemical pregnancy loss. Biochemical pregnancy was negative for the female partner. And these were the other investigations which have been ordered outside. So the serum follicle stimulating hormone was mildly increased, just 18 international units per liter. The LH level was also mildly increased, and the AMH level was reduced with the normal TSH and prolactin levels, and suggestive of a possible low or impending ovarian failure. The radiological evaluation, pelvic ultrasonography revealed a small uterus with bilateral small ovaries with reduced follicular count, and antral follicle count was 3 to 4 follicles bilaterally.
So thank you, Dr. Valli. So now, with this kind of a profile, Dr. Lakshmi, so I would like to ask you, so is this patient, would she be said to have premature ovarian insufficiency, and how do we recognize it? And has there been any change over the years in what do we call POI, or what are the cutoffs which are being used as compared to the older criteria?
Yeah, recently, if you look at this patient, the FSH is only 18 and AMH is 0.6, if I'm not wrong.
Yes, yes.
So that means she is at risk of imminent POI. She is, as of today or when the tests were done, she was not POI, mainly because, the MH is not too low. And sorry, I missed. Does she have regular cycles?
No, she has oligomenorrhea.
Oligo, but still she has regular cycles. So mainly we call POI when the patient has amenorrhea for 4 months or more than 4 months, and then if FSH is more than 25 international units per liter on 2 occasions. So this patient doesn't fall into the criteria of POI as such as on the date of the test, but she is at risk of developing it sooner, mainly because her AMH is less.
So this would be like at this point of time, we can just say that she has a poor ovarian reserve,
Yes,
with an imminent POI scenario.
Yeah.
Okay. So, if I understand correctly, previously the FSH cutoffs were taken as 40 international units. So, what led to the reduction? The cutoff. What was the rationale behind reducing that? Is there any literature on that? Because we also used to think 40
but
only.
Now it's become 25. Yeah, maybe because the tests have become more sensitive. Maybe that we can think about.
Yeah. I think somebody is asking what's POI. So POI is premature ovarian insufficiency. So I think previously the term used was premature ovarian failure, but now it has been called as premature ovarian insufficiency. Dr. Valli, you can go to the next slide, I think.
Sure. Yeah. So premature ovarian insufficiency is defined as loss of ovarian activity before the age of 40 years. It's characterized by amenorrhea or irregular menstrual cycles with elevated gonadotropins and low estradiol. The follicles FSH level is typically like more than 25 international units per liter. Occurs in 3.5% of women in the general population. At least 1/3 to 1/2 of cases remain idiopathic, and many cases have an underlying genetic etiology, especially monogenic causes have also been identified, which we will be discussing.
So I think one more thing which this lower threshold has caused is that previously we used to say that 1% of women qualify as POF when it was called POF, and FSH cutoff was 40, and now probably with the lower cutoff, the proportion also in the recent literature says right around 3.5% women would qualify as POI. So probably our threshold of investigating and intervening has become lower. Yes, that would be the rationale. Dr. Kave, you were wanting to say something, I thought.
Yeah, ma'am.
Did you add?
Hello, everyone. So H-ray has got down this cutoff from 40 to 25 to include a particular group of cases which are autoimmune in conditions, to include them also, because they are the ones which we are dealing during in this infertility field, especially. So including to include them, the H-ray has got down this cutoff.
Okay. Thank you. So yeah, we can move forward, Dr. Wali.
Yes. The case continues. On examination of the individual, the female partner, the general examination revealed her height was less than 3rd centile for her age, and for the sex and the population. Weight was 50 kgs, and there were subtle dysmorphic features in the form of short stature, mild cubatus valgus, short 4th metacarpal, high arched palate, and those were not very classical signs of Turner. Stigmata like web neck, shield chest, lymphedema, they were absent, and the secondary sexual characteristics were also well developed with the breast development of Tanner stage 5. Normal pubic and axillary hair distribution was seen. Systemic examination, including cardiovascular system, was also unremarkable. No significant examination finding otherwise. So here, in view of the subtle dysmorphism and history of infertility, subfertility, repeat karyotyping with 50 metaphyses were ordered. The cytogenetic analysis was done on basis of this finding, and peripheral bed karyotyping using GTG banding revealed mosaicism. It is 45 out of 50 cells counted, 18 cells demonstrated monosome X, and 32 cells demonstrated 46XX, which is normal female karyotype. So this confirmed the diagnosis of mosaic Turner syndrome. And this is just a karyogram to show that 18 cells, 18 metaphases showed 45X, and remaining 32 cells or metaphases showed 46XX.
So, Dr. Shagun, would you like to do any additional workup with this diagnosis, and how would you proceed further in the investigation in terms of genetic evaluation?
So, as Dr. Valli mentioned, so because this patient did have some clues on examination, so one of the main clues actually which was there was the short stature. So again, we need to remember that not every lady with Turner syndrome would have the Turner stigmata. So, but one of the things which is invariably there is short stature. It may not be marked short stature, it may be just borderline short stature. So any lady with the POI phenotype with borderline short stature, we should immediately kind of start thinking about Turner, and because many of these would not, like in this case now, it's a Turner mosaic. So Turner mosaics will not really present with the classical Turner of primary amenorrhea and gonadal dysgenesis kind of picture. They will present like this very often, where they will have some menstrual cycles and then they go on to develop a POI picture and present with subfertility. So again, the short stature gives us a clue, and then in that case, we ask for those 50 metaphases. So that's one important thing I want to highlight, that usually labs will check only 20 metaphases. But if we ask specifically for 50, then we can analyze and then we can detect these mosaics. And then once we detect this, like that this patient is a mosaic Turner and that is causing the ovarian insufficiency. So then we have to again remember other things, that Turner syndrome per se is associated with other anomalies, especially cardiac anomalies, whereby mostly either it can be coarctation of aorta, which milder may again go unnoticed, may present with mainly early onset hypertension kind of picture, or they could even have a bicuspid aortic wall, which as such remains asymptomatic, but sometimes during pregnancy or otherwise also, then some patients may go on to develop some amount of aortic regurgitation, and that may again result in certain complication. So again, once we make a diagnosis of Turner, although she's mosaic, but we will ask for an echocardiography. And then we also ask for a kidney ultrasound, because again, renal anomaly, especially horseshoe kidney, is pretty common in Turner syndrome. Again, per se, horseshoe kidney does not cause any harm, but then again, suppose during surgery, wherever, we are doing a laparotomy for whatever reason, you may end up injuring the kidneys if you're not kind of, careful about the location and all. So it's good to always have an renal ultrasound in these patients. And also they are prone to develop autoimmune conditions, especially thyroid antibodies, so thereby hypothyroidism. So again, we usually advise for yearly thyroid profile, also blood sugar, blood pressure monitoring on an yearly basis. And then of course, due to the ovarian insufficiency, it seems that she already also has some degree of osteopenia. So these are some additional things which we do advise for Turner patients for their well-being per se. So we'll go to the next slide. Yeah, so in addition, of course, the other aspect which becomes important is now counseling from our point of view. So we have found the cause of ovarian insufficiency, but of course now we know that this is not as such. As of now, she is in the scenario of, at present a reduced ovarian reserve. So from our point, we would be counseling her that there is a risk that she is going to eventually develop in complete ovarian insufficiency, and for that she may require additional care. And with respect to the fertility options, then we would be referring them back to you now to discuss what other options now is there, because her primary concern at this point of time is with respect to fertility. So, so now, we would be sending them back to this lady back to you, Dr. Lakshmi. So now what management options are there for her, especially with respect to fertility at this point, which is her primary concern?
So as mentioned in the history, she has been trying for the past 5 years. So we shouldn't be delaying further and wasting her time just thinking of just ovulation induction or IUIs. First, we need to look at husband semen analysis and then counsel them for self cycle, because her antral follicle count is low, but not like she has only the option of donor eggs. So first we would definitely counsel her, give her both the options, and saying that because of the poor ovarian reserve or less follicles, she has a risk of low success rate. And on top of that, there is a risk of miscarriage also in these women, because the oocytes are having this problem of aneuploidies. So this needs to be highlighted to these patients, because they might conceive. The chances of conception with their own eggs is around 30%, but at the same time, they might end up, even after conception, they have this risk of miscarriage. So that needs to be highlighted. And if at all the law allows us, I would suggest that we can go even for preimplantation genetic and testing for aneuploidies, because of the high risk of aneuploid eggs in these patients. As not only in these patients, but whoever who has low ovarian reserve, they would be benefiting. We can reduce the risk of miscarriage in these women if they are undergoing IVF. And at the same time, I would also counsel them in terms of donor oocytes, give them the success rates, and allow them to make the decision, informed decision. And all this also depends on the husband semen analysis as well.
And what would be the role of oocyte cryopreservation, let's say, like for now, of course, we help her with this pregnancy, but for future pregnancies, like, would it help if we would also simultaneously,
All
the
the
gestation
patients,
reserve.
yeah, definitely all patients who have low ovarian reserve, they're not planning pregnancy, oocyte if they don't have a partner, oocyte cryopreservation will be an option. But if they have a partner, then embryo cryopreservation is what would be suggested. And regarding for future pregnancies, definitely the concept is going towards completing the family and number of children they want to have and planning from the beginning itself in terms of freezing the embryos so that, after the first baby, they don't have to struggle or go for embryo donation. That's a good point, Dr. Shagun, that you have highlighted. Definitely, we should be planning for their family, not just one kid.
Thanks, Dr. Lakshmi. Yeah, we'll move forward, Dr. Lali. Yeah, so this
Yes.
we have discussed already. So
Yes. Yes. So the further plan for this patient, given her residual ovarian function, control ovarian stimulation with IVF, for this patient was planned. And she was also counseled regarding obstetric risk associated with Turner syndrome, need for cardiac surveillance during pregnancy. Mosaic Turner syndrome, it often presents with a milder phenotype, unlike the classical phenotype. This may delay clinical recognition and diagnosis because a lot of these patients come with a history of subfertility or infertility as the main or the first presenting complaint. Approximately 5 to 10% of women with mosaic Turner syndrome experience spontaneous menarche, and some individuals retain residual or intermittent ovarian function also. However, ovarian function is often transient. They may go for low ovarian reserve or ovarian failure later on. Primary subfertility may be the initial presentation, like I told already, and underlying cause is basically reduced ovarian reserve and accelerated follicular depletion. Clinical implications of diagnosis is not just for the reproductive options, but also for her own well-being, like what ma'am has discussed already, for cardiac surveillance and other anticipation of other risk. It is always recommended that a woman presenting with short stature, with subtle features, or may not even have any dysmorphism as such, short stature with unexplained infertility, it is worth while doing karyotyping with increased metaphases, like at least 50 metaphases. Importance of identifying mosaic Turner syndrome, like already discussed, appropriate fertility counseling and management we can offer, assessment of pregnancy-related risk, and long-term surveillance in the form of for cardiovascular complication, endocrine disorders, metabolic abnormalities. All these can be, at least for surveillance care plan can be given to them. And I would like to discuss briefly other causes of premature ovarian insufficiency. So X chromosome rearrangement, some of these deletions involving X chromosome and translocations are known to be responsible for premature ovarian insufficiency. Particularly XQ26.2 to XQ28 this region, the cytoregion appears to contain a critical region for normal ovarian function. When this gets disrupted due to some translocation, some other rearrangement, then they may experience infertility or subfertility. So this is just a case.
Can I just interrupt here before you go forward?
Yes, Doctor.
Do I have permission? Yeah. So
yes.
Typically, madam, the one thing I want to tell everybody about the Turner's thing that we understand today is that always 1X is inactivated. There's only 1X that is working to maintain parity between a male and a female. 1X is always inactivated in embryogenesis. But 20% of the genes on that inactivated X escape inactivation.
Yes.
And
that's a pseudo-autosomal region, actually.
Yeah. So because 20% of those genes do not undergo inactivation, that is where the shock genes, etc., are present, which are important for allowing antral follicular development. See, there are oocytes, there are those primary, there are those cumulus cells, one single layer of cells. So these antral development is controlled by those genes which are present in that 20%. So whenever there is a Turner, you don't have 1X. You have only 1X. And that is why those genes are not present, and that is why you have this problem. Now, when you have a mosaic, you do have some cell lines having some amount of gene material. That is why what happens is you will have some primordial follicles because the shock genes, etc., are there. But the next step is from the primordial follicles to go forward into folliculogenesis. There are some more genes required, multiple sets of genes required, and they are not activated. They are not present in full. And that is why a Turner mosaic behaves differently from a regular Turner's, because the reason for this entire pathology is in terms of fertility, what I'm saying is because the genes, that 20% of genes are normally escape inactivation. But in a Turner, the whole X itself is not there. So the load of genes is less. And that is why you don't even have primordial follicles developing.
Yeah, that's
Thank
right,
you.
Observe. Yeah, thanks. Yeah. Okay.
So this is just a case of Fragile X syndrome. Basically, there's a pedigree of showing a female consultant who is a premutation carrier. Basically, this she has two affected siblings who have been diagnosed with Fragile X syndrome, and this is just the electropherogram, TPPCR electropherogram, which is triplet primed PCR. For repeat expansion. And so here we can, if there's a single peak, it's considered to be normal. And here we can see that ladder pattern. This is a ladder pattern which is showing a huge expansion of more than 200 repeats, which is suggestive of disease range, basically for the affected siblings, male siblings. And the female who is a premutation carrier is at a risk of developing premature ovarian failure. Nearly 15% of POI patients with family history have FMR1 premutation, which is typically between 55 and 200, which is premutation range. 2 to 5% sporadic patients with premature ovarian insufficiency. Approximately 20% of female premutation carriers undergo premature menopause. The risk appears to be greater for premutation in the 80 to 100 range. And also the other implications would be to assess the risk of intellectual disability in male offspring of the carrier female, pre-symptomatic screening of other female members of the family, prenatal and pre-implantation diagnosis will also be suggested.
Just one second, Dr. Vali. So somebody had asked a question in the chat box for Fragile X. So in the previous patient, basically, we don't need to do the testing for this because we've already established the cause of ovarian insufficiency as the Turner mosaic. So when we do for Fragile X premutation testing is when the karyotype is normal. So it becomes especially very important in cases where there is a family history of either POI or family history of intellectual disability in male members. Then we will surely test for Fragile X premutation. And then the second scenario, of course, so in 15% of positive family history, you will find Fragile X premutation actually as the cause. But mostly we get the sporadic ovarian insufficiency. So there also around 2% have this. So once you have rolled out chromosomal abnormality, then we go on as a second tier test for Fragile X premutation testing. And this is done by the test which Dr. Vali showed. That's a TPPCR. Yeah, you can go ahead.
Yes. So these are the other causes, monogenic causes. They are again classified as non-syndromic and syndromic premature ovarian insufficiency. So among the non-syndromic or the single gene defects, the common ones would be FMR1 premutation, which is around 2 to 3% sporadic and 15% familial cases. The other genes involved would be as listed. And syndromic premature ovarian failure, the more common condition would be BPES, which I'll be showing. So here, blepharophimosis, ptosis, epicanthus inversus syndrome. This is another relatively common condition where the patient can present with premature ovarian insufficiency. It's autosomal dominant inheritance, with the risk of offspring being 50%.
Yeah, I think with this, we are seeing now so many genetic causes of ovarian insufficiency. So what test do we recommend finally? So we'll go to the next slide. So this is something which we, of course, as geneticists have been practicing since long, but now 2024 ASRM has given these guidelines. So once you have ruled out the iatrogenic scenario, of course, then for genetic testing, for every case, we need to do a chromosomal analysis. If patient is showing any signs of Turner, even a short stature, then ask for 50 metaphases. If that's normal, then we do FMR1 premutation testing. If that is also normal, then NGS-based testing, typically in clinical scenarios, we don't really order for a non-syndromic ovarian insufficiency patient, because the contribution of all those different genes, what Dr. Valli had shown, is not very significant. So few cases only will have that, and it usually does not impact your management. So that's why we typically don't write unless and until there is a family history. Then we suggest patients to go for NGS-based testing. But if there are syndromic manifestation, then of course we'll order for NGS-based testing. So NGS-based testing for ovarian insufficiency is not routine. It will be usually recommended if there is a positive family history or if patient has some syndromic features. And then basically the relevance becomes for counseling, for management options, especially like for Fragile X premutation testing. Now, we would want to offer them PGT or prenatal testing, depending on whether she's going for ART or spontaneous conception, to prevent the birth of a child with Fragile X syndrome. So that's extremely important. And even for Turner also, we can go for PGT-A also, because these women are also prone to have somewhat aneuploid embryos. So again, that can be suggested and as another intervention. And of course, the monitoring of the patient herself, and another important thing which becomes important once we find the genetic etiology is the screening of family members. So this is especially important not for Turner. Turner is usually sporadic, but for FMR1, so suppose a lady has FMR1 premutation, her sister could also be having. Her sister could be younger than her and as of now not manifesting, but then she would also go on the same way eventually. So that patient, at least that person, we can screen early, we can preserve her oocytes even before she starts planning a family. So the testing has a lot of implications. It's not just for kind of academic interest. It has actual clinical benefits for the patient's management. So next slide, Dr. Valli. So I think another important aspect which I want to ask Dr. Lakshmi is that now this patient, like this, of course, she's as of now not really POI, but a patient who has overt ovarian insufficiency. So besides infertility, what other issues as a gynecologist we need to do surveillance, or she would require management for other concerns related to her health per se?
So, as you have mentioned, Dr. Shagun, yearly tests has to be done, like in terms of echocardiography, thyroid, and bone density. And along with that, we also have to put these women on HRT because they are in a hypoestrogenic state. This is very, very important, especially because majority of the women, they come to us for fertility treatment without undergoing any HRT treatment. So this is very essential. I think most of us are very worried about HRT because of the negative impacts that have been propagated. But these women, as such, they need this HRT, and that wouldn't put them at high risk of whatever breast cancer or any other issues that have been raised by the her study. And then it can be given either in a cyclic way or a sequential way. We can give 17 beta estradiol patches, gel or oral tablets along with medroxyprogesterone estate or a natural micronized progesterone or norethistone estate. And if it is very difficult to counsel the patient, we can even go for oral contraceptive pills, which they can take for 21 days. And that is very important. And we have to counsel them to continue their treatment, maybe beyond 40 years, definitely. And sometimes it can extend even up to 50 years. And this will protect them. This will protect their bones and also the heart. So this is very, very important.
Okay. So then, I mean, a woman who's trying to conceive, for her also HRT would be how do you plan the regimens for such women for HRT and then for achieving fertility?
HRT, I mean, while undergoing IVF treatment?
Yeah.
Yeah. First, we need to look at the size of the uterus. And if it is small, maybe we can give her a pre-treatment for 2 months so that the uterus comes up to a little bit good normal size. And then we can start the HRT for actual embryo transfer. So this we can do it in sync with the donor, or we can freeze the embryos and then transfer just according to her cycle, according to her hormone estrogen supplementation. This we usually do it with 17 beta estradiol or estradiol, estradiol valrate or estradiol hemihydrate. So we start with a period. It could be a withdrawal period in this case, and then we continue the estradiol tablets. Initially, we start with either 4 milligrams or 6 milligrams, which is taken in divided doses, and for up to 10 to 12 days, and then subject them to a scan. And if the scan shows that the endometrium is triple line and the thickness is around 6 to 8 millimeters, we can plan for the transfer. That's when we start adding up the progesterone, the natural micronized progesterone, and plan accordingly. Usually in donor cycles, we do blastocyst transfer. So we start progesterone 5 days before the transfer and plan the transfer. And we continue both estrogen and progesterone beyond the transfer till the pregnancy test date, which is around 10 to 12 days after the transfer of a blastocyst. And if she conceives, then we have to continue the same regime till she is around 12 to 14 weeks, because the body doesn't have the system of producing the estrogen. We have to give it up to 12 to 14 weeks.
And how do you, decide which patient could benefit from like self oocytes, or where would you directly go for a donor oocyte? Or do you give a trial to some patients depending on the number of follicles, and then we decide for a donor?
If it is a premature ovarian insufficiency where she is all like attained menopause, definitely I would recommend to go for a donor egg, because the ovaries doesn't have any oocytes. But if she is perimenopausal, and if we can see a few follicles, there is some AMH available, then we can give the counseling in terms of both self cycle and donor cycle. And if the patient is ready to give it a try and see if she can achieve pregnancy with her own eggs, we have to counsel her in terms of the chance of repeating the cycle, because the success rate is low in these patients with low ovarian reserve. So usually the quote is like around 20 to 30% success per cycle. So if they accept it and if they want to have their own progeny with their own eggs, definitely we should be giving a trial at least 1 or 2 cycles and see how the egg quality is, the embryo quality is, and then decide whether the patient want to continue or not. I had a patient with a very poor ovarian reserve. She is like 28 years with 0.08 AMH. But the patient wanted to try her own. She is a very educated woman. She did not want to go in terms of donor egg. So we tried, and we had frozen 3 blastocysts for her. And we did a PGTA also, and all the 3 embryos are euploid. So we just have to wait for the correct number of oocytes or correct ovarian antral follicle count before we start. We shouldn't be like rushing out to start the treatment. We should wait for us to see the antral follicle count, which can give us the maximum chance. So previously we were thinking of that, okay, once the antral follicle count is low, it won't vary from time to time. It's only the FSH that increases and decreases across the cycles. But now it has changed. There are some cycles where the antral follicle count would be good. And if we start stimulation at that time or in that cycle, the chances of getting more oocytes and better quality embryos is more. So that is one important point I want to highlight. And so if they want and they are capable of spending so much of money because it also comes with finances. IVF cycle is definitely expensive because of the hormones we use and also the lab consumables we use. So if they're able to spend and if they want their own progeny, they still have a chance when the antral follicle count is not 0. But if it is already menopause and they don't have any oocytes, then better to counsel them to go for donor oocytes.
Yeah, thank you, Dr. Lakshmi. I think with this we can end this case. So we have seen how, doing a genetic workup is important for management and how the management also needs to be individualized and also is in terms of a holistic management, not just with respect to fertility. So I think thank you, Dr. Lakshmi, we can go on to the next case.
Thank you, Dr. Shagun, for having me. One important thing is you have asked me about oocyte freezing. So if any one of the family members have premature menopause in the family, so those are the patients whom we have to counsel for ovarian oocyte freezing at the earliest, because there is good evidence to say that if the mother or aunt is having premature menopause, then these people, the girls, also have
also likely to, yes.
but likely to have
but I would add another point here. No, we should also do genetic testing still, because as we showed that case with Fragile X premutation, so some of these women would be having that actually as the reason of the premature menopause. And there the other problem which happens is that this lady now, whenever she conceives through her own egg, which you may have frozen, but the male child of this lady could be born with Fragile X syndrome, which is a serious intellectual disability condition. So, of course, as you mentioned, there is a familial component, but one of the reason for that familial component is this Fragile X premutation, which we should be testing in all women where there's a positive family history, and even others, the ones without a family history, once the karyotype is normal.
Yeah, point well taken. And what will be the cost, if I can ask, so that the audience also will benefit?
For the Fragile X test premutation, it's in our center, it's around 3,000.
Okay, it's not that expensive.
No,
so
not at all. It's a simple PCR test, a specific type of PCR, but we have it in-house. It's not expensive.
Okay, wonderful. Thank you so much.
Thank you.
Can I take the control?
Yes, please.
Thank you, ma'am. So I'll just share the slide, faculty introduction slide here.
I'm sorry.
So thank you to our speakers for this excellent discussion. We now move on to the session 2, focusing on another crucial and often complex clinical challenge, that's male partner infertility. To guide this session along with Dr. Shagun Madam, it's my privilege to introduce our esteemed faculty, Dr. Purnima Durga. Madam is the Medical Director and Chief Fertility Consultant at MOM IVF and Research Center, Hyderabad, and the Joint Secretary of OGSH. Her clinical focus on recurrent implantation failure, thin endometrium, and PCOS reflects a deep commitment to solving some of the most challenging infertility cases. Recognized with multiple prestigious honors, including ISAR Excellence Awards, IHW Leadership Awards, and IVF Achievers Award, she stands out both at the clinical excellence level and patient-centric innovation. Presenting the clinical case for this session is Dr. Pratyusha Koneru, Medical Genetics Resident at NIMS. Dr. Pratyusha, the floor is all yours, and I'm just stopping to share. Thank you.
Thank you, ma'am. Are my slides visible?
Yes.
Okay, so I'll be presenting the second case scenario. This was a non-consanguineous couple referred from a fertility clinic who had complaints of inability to conceive in spite of trying for 5 years. So there was no history of medical comorbidities in both the partners, no prior surgical history or hospitalization. There was no difficulty in conceiving or any other history in the family as well. The wife had regular menstrual cycles with 4 to 5 days of bleeding for the duration of 28 days per cycle. So this is the pedigree. The husband was 39 years old and the wife was 32 years old, and they were married for 5 years. So the investigation wise, hormonal workup was done for both of them in terms of sugars, HbA1c, thyroid profile, and prolactin for the wife, which was normal. The semen analysis showed azoospermia, and the hysterosalpingography showed normal tubal spill bilaterally. And the couple karyotype was done as a part of infertility workup for both the partners was normal.
Thanks, Dr. Pratisha. So I think we'll begin by asking some basic questions from Dr. Purnima. So I mean, as overall for infertility, Dr. Purnima, in your experience and also literature, how common is male factor infertility, and is azoospermia the most common semen abnormality which you're seeing in your practice, or other kind of qualitative defects, are you seeing those more commonly nowadays? And have you noticed any lifestyle, because that's what we are kind of seeing nowadays and reading, and even many patients who come to us also for workup, invariably the semen analysis is showing some or the other qualitative defects. So what's your experience with respect to overall male factor infertility and these semen abnormalities?
Yeah. First of all, good evening, everybody. Thank you for the kind introduction as well. As rightly asked, most common cause, incidence of male factor infertility, to be frank, previously we used to see around 20 to 30%, but now the incidence is almost as equal as 50%, 40 to 50%. And most of the cases nowadays, we are seeing both male and female factor together. So I can say that the overall incidence of male infertility can be around 40%. And second, can you go back to the question slide?
Yeah.
The
I
second,
just want to understand that, because when we see literature, literature is saying that, azoospermia is the quantitative defects are more common, but actually even what we are seeing couples refer to us, most of them have qualitative defects nowadays. So what's your experience?
So basically, my experience probably in my practice azoospermia, I could see around probably 5% of cases. The most common semen abnormalities we are seeing is in the morphology, to be frank. We're seeing very poor morphologically poor sperms nowadays. And the most common, we all know that the counts might be low, where we call it as oligospermia. If the motility is low, we call it as asteno. And the shape or the morphology of the sperm is bad. So these are the most common parameters which we see teratospermia. But the most common thing I'm observing in my practice in the morphology of the sperm and the motility issues. So yes, azoospermia, yeah.
And are these related to lifestyle, do you think? I mean,
Yes, 200%. And the other question you asked is, most of these males are hypogonadotropic? No. Actually, when you look at azoospermia, hypogonadism, the incidence is as low as probably around 1 to 3%. The most common cause is probably some obstructive symptoms. Azoospermia can be normogonadotropic or hypergonadotropic. So not all males with azoospermia are hypogonadotropic. Lifestyle factors 200% is, I think you can highlight about the epigenetics also, Dr. Shagun here, how a bit of that. So environment, yes, the lifestyle habits, smoking especially in males leads to the decreased motility and sperm quality, alcohol, sleep. A lot of people now, there is a lot of focus about the stress and sleep, and also the working atmosphere, and to be frank, the type of clothing the men use, and the cell phone radiations. So, and the drugs, and exercise also. In fact, moderate exercise is good, but high gym, the males with go to gym and take some supplements, they're coming with low testosterone. So there are a lot of lifestyle factors that do affect the male factor infertility. When you are taking a history, it should be a detailed history about the drugs, lifestyle, and previous, obviously, fertility treatments or surgeries or whatever. So lifestyle plays a very huge role.
Right. That's what even like we are also seeing that, most of the couples are coming to us for genetic workup. Majority of them, like one, as you mentioned, there are dual factor, male, female, both. And then in the
Yeah.
males, invariably there are sperm morphology abnormality, even if the count is good. So that's something,
Yes,
but
exactly.
most of the time, I think those factors, the qualitative ones are still correctable. Whereas the ones where we get more concerned are, the one where there is azoospermia or oligospermia, and there many of them do have genetic abnormalities. So I think we'll move
Yes,
forward,
exactly.
Pratyusha. Yeah. So yeah, so then of course, you mentioned again, obstructive is pretty common. So like, how do we kind of distinguish obstructive and non-obstructive azoospermia, and does it really impact like how you're going to manage that case? So, would you like
Yeah,
to?
when you want to distinguish, yeah, when you want to look at the obstructive and non-obstructive, you can start with looking at the semen analysis. In obstructive, obviously, when you look at the semen, volume will be low, and in non-obstructive, the volume will be normal. And when you look at the fructose, in obstructive cases, the fructose in the semen might be absent. From the semen analysis, you can go for hormones. Hormones will give you a lot of information, whether it is a obstructive or non-obstructive. Generally, in obstructive azoospermia, the hormone levels are pretty much normal. In non-obstructive, the hormones might be high, FSH and LH might be high with low testosterone and all. And the third important thing is definitely the clinical examination. When you look at the clinical examination, the test size might be normal. You can, in obstructive cases, you may see VAS absent in some cases, congenital absence of VAS, or the ejaculatory duct might be thick. In some cases, varicocele can be there, but in non-obstructive, generally the testis of size will be small. So when you look at the difference, you have to go from the basics, from the history, and from the clinical examination. Then comes the semen analysis, then comes the hormones, then comes the imaging aspect, where you can look at the size of the testis, presence of varicocele and all, will also gives us a lot of information. And in cases when you are suspecting absence of VAS, then probably going for a transrectal ultrasound can also give you a lot of information how to go about it. And the gold standard, as we know in azoospermia, is definitely testicular biopsy, where the retrieval of sperm is better in obstructive cases when comparative to non-obstructive, which gives you a gold standard diagnosis of azoospermia. So probably these are few ways how you can evaluate an obstructive azoospermia from a non-obstructive azoospermia.
And I think,
Yeah.
of course, I mean, as you mentioned, so the testicular biopsy finding sperms there would kind of clinch the diagnosis, and that would also tell us that this patient would respond now to, we can go ahead and do an ICSI with his own sperms, right? As compared to
Yeah.
where there is a
Yes. Yes.
testicular failure where
Yes.
you don't find sperm. So then, though, of course,
Yes.
they have to go for a donor, right?
Yes.
Okay. Yeah.
Yes.
So, so I think, okay.
Yeah, Dr. Shagun, I think I want to ask you about the genetic etiologies of azoospermia, how to go about it, being a fertility specialist. If I'm seeing this, what are the genetic tests I have to order, and what are the genetic etiologies of azoospermia, and how common are these? Like do all cases of azoospermia need to go for genetic testing, even though they are obstructive? Or like, what's your take on this?
Yeah, so I think, again, we also do the first, the evaluation in the sense to say whether it's obstructive or non-obstructive, because that again, whatever you mentioned, the same points we would also elicit, because that also decides what genetic testing we want to do. So for obstructive, if we are looking, at genetic etiology, so as you rightly said, so it's the absence of vas deferens, which is seen in around 6% cases of azoospermia. So where again genetically it becomes extremely important, because a large proportion of these people, around 60 to 90%, have a mutation in the CFTR gene. And why this becomes important is because this person per se may be having the absence of vas deferens due to this gene. And then, of course, if you do a testicular aspiration, you can easily find sperms and they can be used for ICSI. But then, if the female partner also ends up having a mutation in the CFTR gene, then their child can be born with cystic fibrosis, so which is a very deep, debilitating genetic condition. So that is something we need to prevent. So that's why if we
Dr.
find,
Shagun, if I
yeah,
can ask you one question here. If you are advising this CFTR gene, do we need to do for both the partners or one part? For the male, if you do for the male, it's fine. If it's positive, then no need to test the female. Like how
Yes,
to
that's
go
right.
about
So
it?
first we do for the male. So again, even when we do for the male, we have to remember that for CABVD, typically in the patient will usually have two mutations in the CFTR gene. One of them will be a common, will be a mutation in the exonic or coding region, which will easily be found by doing a sequencing. But actually, the other mutation, like there will be two copies of the CFTR gene. So one mutation is a clear-cut pathogenic mutation, which is found by usual exome sequencing of the gene. But the other mutation typically in CABVD is an intronic polymorphism, so which the lab can miss. So we first thing, even for the male partner testing, we have to be careful to, tell the lab that this is what we are looking for, so that they specifically look for that intronic variant. So that is very important to communicate to the lab. And then once we find in the male partner, even if one variant you have found, then we can go ahead and test the female partner. But if you don't find any mutation in the CFTR gene in the male partner, then we don't need to really test the female, because not every case will have, right? 60 to 90% have. The rest, it's just a sporadic absence of the VAS difference. So we don't really need to do both together, unless, it's like there is some issue, like, time is not there, or some other concern where, you want to just save time and do both together. Ideally, we would do the male first, and then, if positive, then female. So
Madam,
that's
I just want to ask you a question. What if both the partners are carriers for CFTR?
yeah.
They
So
carry
in
the
that
same.
Yeah, so in that case, the risk of their child being affected with cystic fibrosis is 25% if they use their own gametes. So in that case, if they are going for IVF, then we have to offer them PGTM for the CFTR variants. So that's the reason we want to basically test always.
Yes, ma'am. Yeah. Thank you.
So then the other important, but the more common scenario is actually the fact where you have a non-obstructive azoospermia. So in that scenario, in fact, there is a very significant proportion of cases who would be having a genetic etiology. So to answer your question, Dr. Purnima, that should genetic testing always be done? The answer to that is yes. So even if we find, some, let's say you found varicocele, grade 3 varicocele, and patient has azoospermia, I cannot immediately jump to the conclusion that varicocele has caused the azoospermia. I would still test. Even if there is a history of, let's say, mumps, then also I will still do the genetic testing, because some things may, because one thing, of course, it's so common to find one or the other genetic abnormality, and sometimes a patient could have two factors also. So we would always want to test a case where you have a non-obstructive azoospermia from the genetic aspect. So as I've written here, so the balanced, so the most common abnormality we'll find. So first we'll do a karyotype. The most common abnormality we'll find is Klinefelter syndrome. So that's seen in 15% of azoospermic men and 5% of oligospermic. And the equally common ones are the Y-chromosomal microdeletion, again in similar proportion of patients. And then there are also around 6% males who would be otherwise eugonadal but have azoospermia, and whereby you will find a balanced chromosomal rearrangement in them. Okay, so for this reason, these are actually the commonest cause, we could say, of azoospermia if we take as a whole. So a genetic evaluation in azoospermia is mandatory, basically, irrespective of,
Yeah, exactly.
is another cause.
Yeah. Probably some take-home point from this is generally we in fertility also, when we see azoospermia, we directly go to TISA. So some people might directly jump. So the take-home message is do one karyotyping and one Y chromosome microdeletion before going for testicular sperm aspiration.
Absolutely.
Yeah,
Absolutely.
exactly.
Yes.
That's the take-home point. Yeah.
So I think we'll move forward with the case, because this case had actually a normal karyotype. So now we see that what next was done here. Dr. Pratyusha, yes.
Continuing the case presentation, so we did the Y chromosome microdeletion study, and it showed the absence or deletion of the AZFC region. So the down below is the gel image of the patient. The first two ones are for the negative controls, which are and then the second two are the positive control, and the SY14 probe is for the control of the Y chromosome. And the other probes which are seen here are for the three regions of the AZF, A, B, and C. And we can see that there is deletion or absence of band for the probes SY254 and 255, denoting deletion. So Y chromosome infertility has a prevalence of 1 in 2000 to 1 in 3000 males, and frequency of Y chromosome microdeletions is 20% in azoospermic men and 5 to 15% in severe oligospermic men. Clinical features wise, they have history of infertility, but their examination wise, physically they are normal. 70% of cases with Sertoli cell only syndrome may have small testes, but otherwise no other signs of hypogonadism. Lab investigation wise, semen analysis may show mild oligospermia to azoospermia severe, and there may or may not be morphological abnormalities. And testicular biopsy, again based on the severity, may show either Sertoli cell only syndrome, where there are no germ cells, only Sertoli cells in the tubules, or maturation arrest with spermatocytes but no mature sperms. So the genetic test that we do is the Y chromosome microdeletion study. This is the schematic representation of the Y chromosome. To the left, we can see the short arm of the Y chromosome, the centromere in the middle, and the long arm. So this AZF region, which is azoospermia factor, this is present in the long arm of the Y chromosome, and traditionally this was so this region contains the critical genes responsible for spermatogenesis. Traditionally, it was called AZF-A, AZF-B, and AZF-C. So currently, now because of sequencing technology, so these have again been newly classified based on the breakpoints, which denote the size of the deletions, the common recurrent deletions, into different categories again.
So, Dr. Shagun, how does detecting the Y chromosome deletion impact your management? I think here the prognosis is good in this patient, probably C region. Yeah.
Yeah, so actually, as Pratyusha has said, so we have these three critical regions which are there. So in fact, the majority, as you're saying, Dr. Purnima, the majority are the ones actually who are the good outcome ones, in the sense that they have this AZF-C region deletion. So, so this is seen in around, Y chromosome deletion per se, around 70% plus patients have actually deletion of this region. And this is a good outcome scenario, in the sense that many of them actually don't even have azoospermia, they'll have more of oligozoospermia. And even if they do have azoospermia, if we do TISA, you'll find nice sperms, mature sperms and all. So these are actually, majority of these Y chromosome deletion cases will fit here. So where easily many of them are actually even spontaneously fertile, or even if they are not spontaneously fertile, easily they will kind of respond really well with ICSI. So this majority will be here in this scenario. But then there are the ones who actually have a deletion of this AZF-A region, or the ones who involve AZF-B or mixture of AZF-B and C. So these are more trickier cases. So this AZF-A deletion actually, although it's rare, but then it has a very severe phenotype of Sertoli cell only scenario, where you would absolutely have no, spermatogonia in the testes. So actually you can even avoid a TISA. Once you do the molecular testing and you say that patient has AZF-A deletion, there's no need to even, go for a TISA and to attempt ICSI. He will need to go for a sperm donor only. And whereas the one which involve B and C to varying degrees, like depending on the size of deletion, they can have sometimes, mainly problems with the maturation of the sperms. So they also kind of usually respond well enough to ICSI. So that's why kind of knowing the type of deletion kind of helps us in planning that, what is the best next step for this patient to achieve fertility. So that is one aspect. And the other aspect is with respect to, kind of counseling of these patients. So like, if we see scenarios, Pratyusha will go to next slide. So if we see scenarios whereby, we have some other problems like some balanced rearrangements kind of thing, where actually there is also an impact on the progeny in some, in the sense that the baby could be born abnormal because of the chromosome problem in the parent. But
Yes.
in this Y chromosome deletion, nothing of that sort will happen. So this just causes, these genes are mainly responsible for the spermatogenesis. If they are deleted, it does not impact in any other way. It does not kinds of cause any problem later on to the offspring per se in terms of any other systemic problems and birth defects or intellectual disabilities and things like that. But then, of course, the other issue also, which we need to always remember to tell these patients is that because this is in the Y chromosome, so all the male offspring of this person will also get his Y. So that male offspring will also get the deletion, and that male offspring is also going to be subsequently have fertility issue when that person grows up. But there are not going to be any other, problems with this person. So
Okay.
yeah. And one more thing,
Yeah.
I think we
Yes,
sometimes get asked this question, in referrals that, is there a role of PGT? Again, there's no role of PGT for this Y chromosome per se as such, because as I mentioned, so all the males will get the deletion. The females will never get the father's Y, so the female offspring will never have the deletion. So doing
Yeah.
PGT for this Y chromosome microdeletion has no meaning or no relevance at all.
Okay. Sure. Good.
Yeah. So next slide. Yeah. So I think Dr.
This-
Pratisha can summarize. Yeah.
Yes, ma'am. To summarize the genetic causes of azoospermia, most commonly they are chromosomal abnormalities, which may be a Klinefelter, which is 47XXY, or a balanced chromosomal rearrangement in the partner, or rarely 46XS disorders of sex development. And then the next common ones, equally common, are the Y chromosome microdeletions. And then rarely the monogenic causes, which are a congenital absence of bilateral vas difference due to CFTR pathogenic and hypomorphic variant, and primary ciliary dyskinesias, androgen insensitivity syndrome, and genes involved in spermatogenesis, which are non-syndromic, but this is a little rare. Most commonly characterized is the TEX11 gene.
Thank you, Dr. Pratisha. I think, Monica, you can take over.
Thank you.
Yeah, thanks, Dr. Purnima.
Thank you, Dr. Shagun. Thank you.
Yeah, thank you so much. I think we'll have one small recap. So, Monica, you can introduce the speaker for the recap of this session.
Sure, ma'am. I'll do that. Let me just share the screen. Okay. Thank you, Dr. Pratyusha and our expert faculties for that compelling case. So to consolidate our learning so far, we will now have a brief recap on genetic testing in infertility. Delivering the recap session is Dr. Rupadarshini Balan, Assistant Professor of Medical Genetics at NIMS, with a strong academic foundation, MS, DNB in Obstetrics and Gynecology, and DRNB in Medical Genetics. She represents the new generation of clinicians who are integrating obstetrics with advanced genomics. She has expertise in clinical genetics, fetal medicine, and fetal autopsy. Can you kindly mute yourself? Guiding this recap as our expert faculty is Dr. Shobha, Professor and Head of Department and IVF Director at the Gandhi Hospital, bringing over 35 years of unparalleled experience in obstetrics and gynecology. Over to you, Dr. Rupadarshini. I'll just stop sharing. Thank you.
Thank you for that kind introduction. So let me share my slides. So I hope my slides are visible.
Yes, just
Yes,
make
ma'am.
it full screen.
Yeah. Okay. So we'll just recap what was discussed in the previous two sessions. So just 10 minutes of your time. So what all testing to be done in case of infertility? So genetic testing in infertility, when to test, what to test, and why it matters. So in female infertility, the first and foremost is whenever the female is having premature ovarian insufficiency, we will first test we will do is a karyotype, especially to look for balanced chromosomal rearrangement and mosaic Turner syndrome. And if both of these tests are negative or normal, we'll go for FMR1 pre-mutation study for Fragile X carrier status. And if that is also negative, then we will think of NGS-based testing, but NGS-based testing is not always advised, but it can be advised or used in consultation with the clinical geneticist. Previously we saw that why premutation carriers are going on to develop ovarian failure. So little bit the basic mechanism why it is causing ovarian failure. So Fragile X syndrome is a triplet repeat disorder. So the CGG repeats are increased beyond a threshold to cause Fragile X syndrome in the male offsprings. So it is an X-linked recessive disorder. So mothers are going to be carriers. So these mothers, when they are carriers for this premutation means the repeats are within 55 to 200. So full mutation comes in the male offspring, premutation occurs in the carrier mothers. So when they are premutation carriers, this Fragile X protein is very important for maintaining the germ cells in the ovaries. So when it is mutated, the adequate protein is not produced. So the germ cells undergo apoptosis and leading to ovarian failure. So the next possibility is monogenic causes. Monogenic causes in the sense single gene causes. Whenever there is defect inside the gene, it is called a single gene etiology or monogenic premature ovarian insufficiency. So whenever your karyotyping is normal, FMR1 premutation is negative, and it is very early onset POI with family history and consanguineous parents, you definitely have to refer them for genetics, further genetic evaluation, especially through NGS-based testing. NGS is nothing but next generation sequencing-based test, and it is called exome sequencing in other terms. So many different genes are implicated in causing premature ovarian failure, at least some 20 genes now. So, these are a list of genes. Some few genes I have mentioned here: FSHR, FIGLA, NR5A1, BMP15, and so on. So they have different patterns of inheritance like autosomal recessive, dominant, X-linked, and so on. So whenever you see a patient having syndromic features along with ovarian failure, so for example, there is one case here which is called BPES, which is caused by homozygous mutation in FOXL2 gene. So this is called blepharophimosis, epicanthus inversus, ptosis, along with ovarian failure. So these females have this characteristic facial features, so you can make out at a distance that this is BPES. So whenever you find these syndromic cases, like they have ovarian failure along with other systemic manifestations, it is better to refer to a geneticist for genetic counseling and followed by genetic testing through next generation sequencing. And another syndrome usually we come across is Perrault syndrome. So Perrault syndrome, they have neurological deficits along with sensory neural hearing loss and premature ovarian failure. So whenever they patients have this condition, you can refer them to a genetics specialist. And the next thing is PCOS is not responding. You have to think of genetic etiology. So we can screen them with 17-hydroxyprogesterone. That is a very simple test. If you see elevated 17-hydroxyprogesterone, then you think of non-classical congenital adrenal hyperplasia. And you can further do a genetic testing for CYP21A2 related congenital adrenal hyperplasia through NGS plus MLPA. So there's a comprehensive testing for this condition, which is called NGS plus MLPA. So you can do this testing to confirm the diagnosis. And you can start on therapy also. So next we go on to the central causes. So we should not miss the central causes. So in central causes, you find low FSH and low LH. So these are otherwise called hypogonadotrophic hypogonadism. So mostly they will present with amenorrhea, but sometimes rarely we do see people who in the initial few cycles, they'll be menstruating and they go on to develop secondary amenorrhea as well. So in these cases, you have to evaluate further, especially when they are having infertility with no smell, think of Kallmann syndrome. So there are many different genes now identified causing Kallmann syndrome. So NGS-based exome sequencing will help in identifying the diagnosis. So when IVF fails repeatedly, think of empty follicle syndrome. So there is this term, I think all fertility specialists should be aware of this term, oocyte zygote embryo maturation arrest or azema. So here sometimes what happens is there is absence of the zona pellucida, resulting in degeneration of the oocytes, so which is called empty follicle syndrome on IVF procedures. So nowadays, even single gene causes for this empty follicle syndrome has been identified, especially in ZP3 gene, FSR gene, and LHCGR gene, etc. So many genes are implicated. So in these cases, in order to help in future implications for counseling of the couple and to help them choose a donor ovum, you can do a genetic testing and you can refer them to a genetic specialist. So when we can suspect empty follicle syndrome, when there is oocyte retrieval failure, normal follicle growth, but eggs are absent or stuck to the follicle, poor granulosa cell proliferation, zona pellucida is absent. So in these cases, you have to have a suspicion and order NGS-based exome sequencing. So coming to male infertility genetic causes, so we already saw there are two types of semen abnormality, obstructive and non-obstructive. So in non-obstructive, whenever you have high FSH leading to azoospermia or oligospermia, you have to do a karyotyping in order to rule out Klinefelter syndrome and also to look for balanced chromosomal rearrangements. And the next genetic testing will be Y chromosomal microdeletion study, as was discussed with Dr. Pratyusha, through multiplex PCR testing. So if both of these are negative, then we can think of a non-genetic cause probably. And whenever there is obstructive azoospermia, I think it is better we refer to a clinical geneticist so that couples counseling can be done for CFTR assay. So if we are thinking of cystic fibrosis, then we'll have to do exome sequencing in the male partner first. So otherwise, if you want to save time and if you want to see whether the baby also will be affected with cystic fibrosis, then both fathers and mothers testing can be done simultaneously through exome sequencing to look for CFTR variants. So Y chromosome microdeletion we discussed already. So this Y chromosome Q arm contains essential genes for meiosis, germ cell proliferation, and sperm maturation. So whenever they are deleted, they can lead to semen parameter abnormality. So the most severe form is AZF-A, where it leads to pre-spermatogonial arrest itself. So we'll have very 0% sperm. So T success is very, very poor. So it helps in kind of prognostication, and you can directly go for a donor sperm instead of trying Ts. And so last session already ma'am discussed that the takeaway point with Y chromosome microdeletion is that it is going to be inherited to all their sons. So preimplantation genetic testing is not feasible for this. And when the guidelines also say that whenever there is severe oligoazoospermia in the male partner, you have to do a karyotype as well as Y chromosome microdeletion study. So, so when you see the semen morphology and motility is abnormal, but his hormone levels are normal and still infertile, then you have to think of tubal ciliary dysfunction. It's called cartilaginous syndrome. So it's a triad of situs inversus, bronchiectasis, and sinusitis. So whenever they have respiratory symptoms, also think of cartilaginous syndrome, and genetic testing will help in prognostication and also help in counseling of the patient. So in females also, ciliary dyskinesias can cause ovum pickup problems, embryo transfer problems, despite having normal function and normal ovarian function. So these people, when you try IUI, it will lead to there is a high risk of ectopic pregnancy because of the poor ciliary motility in the tubes. So it is better that if they are diagnosed to have ciliary dyskinesia in the females, it is better to go for IVF rather than IUI. So coming back to hypergonadotrophic hypogonadism, so when you do karyotyping and we have done Y chromosome microdeletion study and you still think it could be something genetic, then you can do exome sequencing to look for hypergonadotrophic hypogonadism in males. So some genes, many genes are implicated. Two of them are listed here. And steroidogenesis also. So whenever the male is presenting with some hypogonadism like decreased facial hair or body hair, and they're having some disorder of sexual development, means there is ambiguous genitalia. So then you have to think of genetic problems, especially related to steroid synthesis. So in this steroid synthesis also, many genes are causing this problems related to steroid synthesis, especially this HST17B3 where there is high androstenedione and low testosterone, NR5A1 where there can be testicular dysgenesis as well as sometimes SMN abnormality because of low testosterone, and there is SRD5A2 because of due to which we can have increased low dihydrotestosterone because the peripheral conversion 5-alpha reductase conversion is deficient. So whenever you see a man with hypogonadism, it is always better to refer to a endocrinologist as well as a genetic specialist. So that a comprehensive analysis will be possible and prognosis can be explained to the patient. So genetic testing in infertility algorithm for
first thing gastric
mute Monica. Let's mute.
Yeah.
So as simple as this slide for female infertility, POI, karyotype, FMR1 followed by NGS. In hyperandrogenism, if 17-OHP is elevated, do CYP21A2 testing. In male infertility, if azoospermia is there, karyotype with Y chromosome microdeletion. If you are having CBAVD, think of CFTR. And if there is syndromic or strong genetic suspicion, any other cause, refer to clinical genetic specialist. That's it. Because all the genetics workup, I don't think fertility specialists, you are already busy. You will not be able to counsel them. You will not be able to test them. So I think that job can be given to the clinical genetist. So proper referral will help in more comprehensive management. Thank you.
I think Dr. Rupa, I have one question.
Yes.
This whole exome sequencing, where do you do this? Like in what cases? You first go with karyotyping, and how much it costs?
So that's what whatever I mentioned on the slide. So when there is a strong clinical suspicion, so males, especially if they are presenting with hypogonadism, with syndromic appearance, and other systemic manifestation, so it is always better to think of something in terms of genetic etiology. And whenever there is consanguinity in the family, their parents are consanguineous, and very young age of onset of premature ovarian insufficiency, and there is family history, another sibling is having premature ovarian insufficiency. So in those cases, we can try to do whole exome sequencing to determine the etiology. And the test cost is usually around, in our setup, it is around 8,000 to 10,000 rupees, ma'am, for one person. It is done in the blood sample. So, but in private sectors, it can be around 15,000 to 20,000.
Thank you.
Thank you, Dr. Rupa, for summarizing the workup. So, Dr. Shobha, ma'am, are you there, ma'am?
Yeah, I am there.
Yes, ma'am.
She has summarized, Dr. Rupa has summarized the two sessions so well and in a very lucid way. And what we have learned from your two sessions is there is good genetic insight has helped us in recognizing infertility as a familial trait, shifting infertility as an individual to the family, so that the treatment is tailor-made to the specific genetic profile. And also this genetic insight is helping us to at-risk family members to have preventive screening and preventive care, like cryopreservation of eggs, sperm, and also embryo transfer, frozen embryo transfer. So she has summarized so well. I thank Dr. Shagun for having given me this opportunity to this webinar.
Thank you, ma'am. We are privileged by your presence, ma'am. Thank you so much.
Thank you, Dr. Rupa and Dr. Shobha, for that excellent summary. Ma'am, am I supposed to take the insights into industry session, or we'll proceed for the next case?
I think let's proceed. Time is, we are overshooting time now. Is it okay? We can have it in the end, perhaps.
Definitely, ma'am.
So please introduce the chairpersons for the next session.
I'll just share the slide. Give me 1 second on this.
Soumya, share the slides once. So while, she's putting on the slide, so I just want to add one more thing. There is also, we are seeing nowadays some referrals whereby there are some NGS-based tests being done for couples to look for certain polymorphisms. So I just wanted to kind of, say that at present there is no scientific evidence or there is no guideline which says that we should be testing for various polymorphisms in these, these infertile couples. So use of technology like exome sequencing, which is a next generation sequencing based technology, it has to be case based and depending on the particular scenario, and it should not be used indiscriminately, because in our OP very often we are getting referrals of patients who underwent NGS based some polymorphism study. So I'm not even sure on what basis certain commercial labs have made those kind of panels, because there is no scientific basis or recommendations or guidelines for those things, and then this causes unnecessary anxiety to that couple who is already distraught. They are not able to conceive, and then on top of that, they come with these 3-4 pages reports mentioning some 10-15 polymorphisms, which actually do not cause them any benefit, rather cause them a lot of psychological harm. So we need to understand that there is, testing with certain cases do need beyond the basic workup, but there is no role at present of for like if karyotype is normal or Fragile X in female is normal or Y chromosome deletion is normal. So there is no role of doing indiscriminate or a universal NGS based testing. We really need to, beyond that, as Dr. Rupa had mentioned, look at the clinical features and see or identify the cases which would need further workup. And then we need to, kind of do the workup, ideally in consultation with a clinical geneticist for those cases. Because basically the purpose of, we always, that medical dictum we need to remember, if you are writing a test, you should know what is going to be the intervention you're going to do on the basis of that test. Is there something which you're going to do? Otherwise, there's no point in subjecting the patient to a test. So that we always need to remember as, practitioners.
That's a very good take-home point, because now a lot of genetic labs, as you said, private labs are coming up with panels like if one IVF failed, we will rule out the genetic. And of late, I've seen all the reports giving the same conclusion, to be frank. Almost I don't want to mention the what it is and how, but the thing is the same conclusion for almost every case. I've seen the report, so I think it's a very good take-home point that we shouldn't over prescribe test for our. We have to do the basic testing, as you mentioned, probably not go for these panels or whatever.
For everybody. There are some patients still, there are some patients still who would need those testing, in certain scenarios, as was mentioned, but not all cases. So those cases we need to be on the watch out for as clinician, look for those odd clues, and then, better to refer to a clinical geneticist so that we can decide, whether patient needs testing and what is the best test for them.
Madam, in few testing reports, we get to see that, there are list of genes which are checked, and, one is hinting towards the probability of a PCO response during the stimulation, and the other gene speaks that, this can be a premature ovarian failure also. Two contradictory things in a report, actually, it doesn't help us to counsel the patient. Rather, it again brings back the whole situation. And initially, like Dr. Purnima said, we used to do the testing, but we are looking forward for, genetist help where, like your previous slides where Dr. Rupa has kept the crux of the testing. That's very, very valid. And I from Warangal refer especially to you and to NIMS. Even my clients wait for hours together is only to get a proper idea and root cause. They need to know the cause. Otherwise, going forward in the fertility practice will be very difficult.
Absolutely. Thank you. Yes, Monica, I think we can introduce Dr. Kavya.
Sure. Thank you. So moving right along to our advanced genetic workflows, we'll go on to tackle the management of a translocation carrier requiring PGT. Joining Dr. Shagun as faculty for this session is Dr. Kavya Rao, Regional Head at OGSH Fertility, with specialized training from Germany and over a decade of experience. Madam has not only led multiple centers across South India, but also has pioneered IVF services in Tier 2 cities, achieving a milestone of India's first Kappa IVM baby in 2023. A recipient of ISAR Young Achievers Award 2024, she has her presence felt globally as a clinician, mentor, publisher, and an academic contributor. Doctor, we are very happy to have you here today. The case will be presented by Dr. Shankar, Medical Genetics Resident at NIMS. Dr. Shankar, you may please begin. I'll stop share.
Thank you for a warm welcome.
So, good evening. Thank you for the opportunity. I'm going to present third case.
Slides are not visible. Slides.
Yes, 1 minute.
నాకు తగ్గలేదు నేను నైట్ ఇది వరకు వాడిన మెడిసిన్ కాబట్టి అది వాడాను
Yes. Monica, please mute.
నైట్
Yes, please go ahead, Dr. Shankar. I think you're muted. Monica, please unmute Dr. Soumya. Unmute yourself, please. Dr. Shankar, unmute yourself.
Coming to the third case, a non-consanguineous couple with 3 years of marital life presented with primary infertility. They underwent an IVF cycle using self-gametes, following which pre-implantation genetic testing was performed. There was significant history in the family that the husband's sister has 2 spontaneous first trimester abortions. Their initial infertility workup suggested essentially normal, except for the borderline low AMH value, and they haven't done karyotype testing.
So here I think I will pause, and Dr. Kavya, I would like to ask you. So like this couple, it seems that besides the borderline low AMH, rest everything looks normal, although they haven't really done a karyotype at this point. So I mean, this is something I think which gets labeled as unexplained infertility. So how common is this, and what is the management protocol, or how is it kind of different from other scenarios? So please let us know your experience, in this aspect.
Firstly, the couple went for an IVF cycle because they were married for 3 long years, and maybe the AMH was an indication for IVF. But to look into the indication for PGTA, they didn't had an indication to go for a PGTA. And now that they went for a PGTA cycle, did they go for PGT, madam, in the previous slide, or just an IVF failure?
No, they had undergone PGT. Actually, they had come to us because of the PGT report only.
Okay.
So, and this
So
is
otherwise,
something
if
again which we are seeing commonly. So that's why I wanted to ask you also, like, is it a routine protocol, for unexplained infertility patients maybe here because the age is a little bit higher, age is borderline. So, do you advise for PGTA for such couples always, or is it an option discussed with them upfront?
firstly, the patient doesn't fall under unexplained with this AMH because it's a borderline low. And secondly, if PGTA was considered in the general population, first the unexplained infertility rules out the ovulation factor, the tubal factor, and the sperm factor. If these three parameters are normal and still if the couple is unable to conceive, we will label them as unexplained. Unexplained infertility, usually if the age of the patient is less than 30 years, if they are young, we can stick to the expectant management and then we can go further after reviewing it every 6 months. But if the age is above 30 to 35, then we will consider an IVF first option. If the AMH, according to the Poseidon criteria, if it is less than 1.2, we will directly advise them IVF. But if it is 2 here, I think we can, according to the guidelines, ovulation, induction, and IUI cycles will be the first line of treatment for them. A couple of cycles, and then if they don't conceive, we will advise an IVF. But again, if the age is above 35, which is advanced maternal age, what happens in unexplained is most of the literature says that there is an oocyte aneuploidy issue where these females above 35 tend to have higher chances of aneuploid embryos compared to the general population. So PGTA is advised only for advanced maternal age group. So unexplained
as a routine, it's not advised, right? If the age is less than 35, then we won't really be advising PGTA. Although, as you mentioned, if there is IUI failure, then they can go for IVF. But
in unexplained, madam, if there is, if this case had 2 previous miscarriages, if it is a repeated pregnancy losses or a repeated implantation failures, then we will definitely suggest for a PGTA. But whenever a case is taken up for a PGTA, I think it is important for us to look for the couple karyotyping. After a failed cycle, always it is important to check for a couple karyotyping and then proceed for PGTA. And I personally, went through the literature about this particular case. It also suggests PGT-SR when there is RPL and RIF for age group above 35.
So I think, but we are seeing, patients coming like this, where, as you mentioned, there's no clear-cut indication here for PGT in this case, right? But this patient actually PGT was done, and this is again something which is getting, I feel, practiced quite widely, whereby patients who are undergoing IVF, so they are given this option of PGTA as a routine that it will help in embryo selection and will kind of help the best embryo and all those things. And many patients are opting, and we are coming up with these scenarios when patients come with this kind of reports to us actually. So
both the ESHRE and ASRM recommendations is very, it's not a strong recommendation. The evidence is very, very less for unexplained if the age is less than 35, madam. It's helping us to decrease the clinical miscarriage. But when we look at the cumulative live birth, there's no difference. And there is a debate about this for indicating also.
Yeah, that's very true actually. But this is again, as we discussed the previous scenario, this is again, I feel, a misuse of technology which is happening, and it's quite, I think, happening very rampantly, I would say. Whereas, as you mentioned correctly, there are very few indications given as per all guidelines for doing PGTA, one, of course, being the advanced maternal age, then RPL, RIF, and severe male factor infertility. So those are the only indications where a PGTA should be done. But again, this is a scenario which we do face very often in clinic. And in fact, now this is the report of this particular patient.
If
Dr.
I was a clinician with this report, madam, I usually get the report like this. I had a similar experience. I see if it is aneuploid or abnormal.
Mm-hmm.
But eye-catching thing is there is this common thing, number 5 and number 10 everywhere.
Yes.
So I think the genetic report for PGTA also, it's saying aneuploid in A. When we go back and see and do the karyotyping reports is when we understand that, there can be some carriers or translocations happening in the couple.
Yeah, so that's what I think we were going to, find in this case. So I will come to that conclusion. And in fact, we would, from our perspective, we always say that any couple going for ART, even if it's unexplained infertility, there's no factor, we should do a karyotype. We should not wait for a failed cycle also. And we'll see how this case is actually, an illustration to this particular point. So here what we are seeing, no? So Dr. Shankar, you can maybe just tell once.
Yes, ma'am. This is a PGT report of 3 embryos. As Kavya madam already explained, these all 3 embryos have aneuploidy. All 3 embryos have same common point is 5th and 10th chromosomes are involved. Except the first one, extra point is the 16th chromosome. So these are the 3 embryos with aneuploidy. Common thing is 10th and 5th chromosomes are involved here.
Yeah. So yeah, so I think this, as Dr. Kavi, you've already raised the red flag here. So we are seeing all the embryos are abnormal and all are involving this 5th and 10th chromosome. So as geneticist, when I see this report, I immediately start suspecting that there is something wrong with one of the partners' 5th chromosome and 10th chromosome, and that's why all these embryos are having abnormalities involving the same chromosome. Of course, one of the embryo in addition has a extra chromosome 16, but extra chromosome 16 or trisomy 16 is very common in human pregnancy. So that is probably just a non-disjunction accidental event. But the other concerning part is the 5th and the 10th chromosome abnormalities in all the 3 embryos. And this,
Madam,
yes.
She is less than 35 and her AMH is 2,
Is 30.
not
Yeah.
less than 1.2. Do you think the ovarian reserve could be a factor if she had any other aneuploidies, if not the same 5 and 10, if the embryos are aneuploid for different reason, at what level you think that the oocyte can be a problem?
No, so then again, see, if the embryos had different chromosomal abnormalities and they were like, 3 trisomies, or like kind of we are seeing whole chromosome 16 extra in one. Let's say the other embryo had minus 5, 5th chromosome, third had some other. So these kind of things are most of the times, they are more like a non-disjunction event. So they are most of the times accidental, and I would not say that this is the cause of the ovarian reserve or the poor ovarian function is causing this. But that being said, there is a category of women which is kind of rarer but probably under ascertained also. So women who have some abnormalities in their spindle machinery. So these kind of women, because of that spindle is what helps in meiosis, the spindle formation. So if that machinery is abnormal, these women tend to have repeated abnormalities or aneuploidies involving different chromosomes. And these kind of spindle abnormality may also be contributing to poor oogenesis per se, and that may be contributing to the low AMH and the poor ovarian reserve. So there would be a proportion of women where this scenario would be there, that the poor ovarian reserve and the recurrent aneuploidies of different chromosomes would actually both be connected due to the basic etiology or the basic pathology of a spindle machinery abnormality. But again, as I mentioned, there is very little work, studies out there, or we don't know exactly at this point of time how common are these these kind of abnormalities, but it's very much biologically plausible. And here also, in this case also, now that I'm thinking that one of the partner has, these two chromosomal, some rearrangement or abnormality involving these two chromosomes, and the lady has this somewhat low side image. So I may kind of, think that maybe she has some kind of translocation or rearrangement involving these two chromosomes that is causing recurrent meiotic errors in her oogenesis and maybe contributing to the poor ovarian result. So that is also one thought which comes to my mind at this point of time. But
Madam, do you think that, any antioxidants what we give before IVF stimulation can help in, improving the genetic makeup, like, the spindle? If it is an abnormality, definitely it is not going to change. But if the oocyte quality improves for this group of women, is there any chance that they will have a better embryo quality or, healthy embryos?
I won't be able to comment much on that. But if there is a really genetic abnormality, then antioxidants will not help. But sometimes, it can be related to certain environmental factors, which are themselves causing certain other, environmental factors causing epigenetic abnormalities, thereby causing certain other, downstream effects. There maybe antioxidants would take care of that aspect. But if there is really a genetic mutation, causing the abnormality, then they won't work.
Yeah.
There is no role.
Yeah.
So here, then that's what. So there are two factors here. What I would say, I think one of the partner has a translocation or a rearrangement involving chromosome 5 and 10. It could be the lady because of this AMH value, or the other history which was mentioned was the husband's sister having two miscarriage. So that also is concerning. So we would like to probe on that also further. Dr. Shankar? Yeah.
Yes. We have revisited history. One of the product of conception, that's a husband's sister's karyotype was done. This is the karyotype report of abortus. There is the extra chromosomal material present over the fifth chromosome, that short arm of the fifth chromosome.
Again, 5.
Yeah,
Yes,
so
yes.
involving again
This
the
is-
fifth chromosome. Yes. So I think, so we did think of this, so that probably that, that abortion in the sister is in some way connected to this. So now that we are finding that, yes, there is some abnormality involving chromosome 5 in that abortus. So now, kind of our suspicion becomes even higher that probably there is some translocation or some other rearrangement event involving this fifth chromosome and the 10th one, because the 10th is the other one which is recurring. And maybe the sister also has this, and this the husband of here in this couple also has the same thing. And that's what is probably resulting in this kind of recurrent aneuploid embryos. So that's why then we have gone ahead and done the couple's karyotype here.
This is the husband's karyotype report. Here, the part of the chromosomal material from the 10th chromosome is translocated into the fifth chromosome. There is no net loss or gain of the chromosomal material. This is a balanced one. This is called balanced reciprocal translocation. Essentially, these persons will be clinically normal, asymptomatic. They may have reproductive issues in different forms. Coming to the wife's karyotype, karyotype is essentially normal, completely 46XY.
Yeah, so before I ask you this, so one more point I just want to make. So there is, I'm sure many people in the audience must be aware. So we have an advanced cytogenetic test now available called as chromosomal microarray to look at the chromosomes. And very often, labs may approach you and they may say that this is a better test, has a higher resolution compared to a karyotype. So this is the test which should be done to look at chromosomal abnormalities. So this is one scenario where there is no role of doing a chromosomal microarray. So this is what we need to understand by looking at this particular karyotype of this person. So as Dr. Shankar mentioned, this is a balanced translocation. So we use the word balance basically to indicate that no genetic material is missing from this person. It is just that the genetic material which was supposed to be on chromosome 10, where the arrow is there, that is the Q arm of chromosome 10. That material has broken from there. It has gone and shifted to the chromosome 5, where the arrow is shown, that is the P arm of chromosome 5. And in as a reciprocal event, some part of the chromosome 5 P arm has gone and got attached to the chromosome 10 Q arm. So there is no net loss or gain of any DNA here. That's why this person is healthy per se. But this is something which will not be picked up on microarray. This will only be picked up on doing a karyotype. So this we need to really remember. There is no role of doing a chromosomal microarray in parents or in couples who are suffering from infertility or suffering from sometimes RPL, and who are otherwise phenotypically normal, because these kind of balanced translocation and other rearrangements don't come in microarray, they will only come in karyotype. So karyotype again is very, very important, and this is one of the classical indication of doing karyotype, where you have a couple with infertility or a couple with RPL also.
Yeah, very good point, madam, which is clinically very important.
Yeah. So I think this is my question to you, because this again is a message we want to give,
So
because we know
karyotyping is not advised for unexplained infertility patients. There's no indication if they don't have any history of repeated pregnancy losses or repeated implantation failures. Second thing, whenever a couple is age above 35 is choosing a PGT option to decrease her time to conception and to have a chance of having a healthy baby, we need to do a karyotype if the patient is wanting a PGT.
Okay, so this was something which, I would differ here. So that's why we wanted to bring this case here. So again, if we look at unexplained infertility, where there is absolutely nothing in the couple workup, around 1% of these couples are going to have these kind of balanced rearrangements. So from our perspective, we would want every couple who's not, it's not like every couple with unexplained infertility needs to undergo karyotype as a routine if they're not going for ART. But like suppose you're trying other methods, ovulation induction, or they're not really going for ART. So those couples perhaps, yes, who may respond to conventional treatment. But at least when you are going for IVF in those situations, we should definitely do a karyotype, because 1% of couples will have these rearrangements. So these kind of couples can then be given the option of PGT SR if they are really going for IVF.
But
So
madam,
that
I
we
think
can make sure,
if that is the point, I think we need to do for all IVF cases, if karyotype.
Yes, it should be done. That's what our genetics guidelines say. We should be doing karyotype for every couple. It's a simple test. It doesn't cost much, and it will help you find out that particular couple who needs a PGT-SR. Because see, if we are doing PGT-A, like of course PGT-A nowadays is NGS based. Even in this couple, PGT-A was only done. SR was not done. And it was able to show this imbalance. But sometimes these kind of translocations and imbalances are very small. Okay, they'll be really tiny, and then in that case, your routine PGT-A may not pick it up, and you may need to do sometimes, PGT-SR, of course, again, NGS based, or at times even FISH if for smaller abnormalities. So it's always good to do a karyotype of a couple before they go for IVF.
But so only thing is, ma'am, the prevalence of this genetic abnormalities in an infertile population, it's being 2 to 5%. Screening, making it as a uniform consensus to screen all the couples might be slightly, difficult for us to convince ourselves and convince them.
May I add one point, Dr. Shagun and Dr. Kavya?
Yes, Dr.
Probably taking age as a criteria might make sense, probably.
No, actually, I would, in fact, that is the second point. So the age does not in any way impact it's not related to the couple's karyotype in any way, actually. So when the age is more, like suppose the mother is advanced maternal age, which we take as 35, then her karyotype can very well be normal, but this lady, because of the advanced maternal age, is prone
Basically,
to
what I
have.
meant to say is
Yeah,
because
yeah.
we are offering PGTA in patients with advanced maternal age, that's the option which we are giving it. So for them, probably testing the karyotype or the, and one more question, Dr. Shagun, I have is, see, basically, as the woman is aging, we are looking for aneuploidies, right? So that's one of the indication where we are doing PGTA in IVF cycles. What do you think about translocations? Do you think that with advanced age there will be translocations also?
No.
No, right? So, okay, that's one thing. So that makes an interesting point that engaged people can also, in case of unexplained infertility, can have translocations. Probably makes
Yes.
sense. Probably.
Yes.
But one
Absolutely.
point from Kavya is also true, ma'am, because it adds to
Logistically,
the
I understand.
logistically and
Yes.
screening genetic cause, as she rightly mentioned, might be too this thing for and to be frank, 30% of our cases are unexplained.
Unexplained.
Yeah,
I
to be
understand,
frank.
but then again,
I just want also to, make a balanced statement here. If we look back into the data of the PGT cases done and indication for them, if it was an unexplained and, we had a right found of those balanced translocations, madam, if there is a good enough retrospective data, or it's not about only with us in India, but worldwide, if there is something really happening, the consensus will definitely fall for the next decade if unexplained infertility couples are having,
Yeah. So again, I think, there is a bit of difference here, because even I went through guidelines of reproductive societies where they are actually not recommending this. But if we look at our genetics recommendation, we recommend. For our point of view, it's like 1% of unexplained infertility is because of these rearrangements. And then it's karyotype is a very cheap test. It's just 1,500 rupees. There's no harm in doing it, right? You are able to at least explain the infertility, because this is what is probably contributing to the infertility, and then you can offer them PGT SR upfront, rather than them undergoing multiple cycles, again having implantation failure if you did not offer any PGT at all, let's say. So
It makes a nice paper for us also to do, Kavya, probably.
Yeah.
Genetic and unexplained, probably we can come together and do some multi-center trial, something, so that we can also come up with our own data. Genetic people are saying, so that we can also come up with some consensus or something.
Collecting the data of these karyotyping
especially makes
reports of
sense.
unexplained.
Yeah, probably we can add, madam, karyotyping. It's a one very good take-home point. Probably I'm taking from today's webinar, probably. Yeah.
So I think the other question, which again gets asked in this scenario, is that, will this, now we are seeing, all the embryos are coming aneuploid. So do they really need to now just go for a donor sperm, or can they, have a normal offspring? So to answer this aspect, because again, this is something which couples, when they come with these reports and this, they get very, very anxious. So Dr. Shankar, we'll go on to the slide, next slide. So again, I don't want to go into too much technicalities. So just to, say that whenever such translocations are there, again, these kind of translocations also behave, different translocations behave differently. Also, we have to always remember, every case is not same. That we already know in medicine, no two patients are same. So here again, depending on which chromosomes are involved, how big is the translocation, different cases may behave differently, but overall, whenever there is a balanced translocation, actually 16 different type of embryos can be formed for such couples, out of which two are normal. So that's this ones, whereby either the embryo gets both the normal chromosomes from that particular parent, or the embryo gets both the translocated chromosomes. So both these embryos are going to be normal. Actually, the gamete and then the subsequent embryo will be normal. This will be completely normal. And this one will be a balanced translocation carrier like the parent. So in fact, nature always favors these two. So even if this couple, let's say not really this particular couple, any such couple with a translocation whom we found due to whatever reasons we did the workup, there is a up to 50% chance that without doing anything for them, their next baby is going to be normal. I'm not telling about this couple specifically because they've already had some infertility issues. But overall, if we see the balanced translocation carriers.
Ma'am, is this for any balanced translocation?
Yes. So overall this is, but again, as I mentioned in the beginning, depending on the chromosomes, depending on the size, some differences can be there in these figures. But these are overall figures that up to 50% are normal actually without doing anything, even if we don't intervene in any way. But then again, this couple is already presented with infertility. So maybe their translocation is causing more, all translocations behave differently at meiosis, so maybe they are more prone, this translocation is more often giving rise to unbalanced gametes. So, but the empiric figures which we take as a group for translocation is that 50% gametes are going to be normal, 50% babies are going to be eventually normal. There is a 25% chance of miscarriage in every conception, and there is also a chance of abnormal baby. That also varies depending on mother is carrying translocation, father is carrying translocation, and there is around 7% chance of infertility. Again, infertility is more common when the male carries the translocation. When the female carries the translocation, she is more likely to have miscarriages. Like in this family itself, we saw the brother is having infertility, whereas the sister actually has RPL. Okay, so this again is known. That is because of differences in spermatogenesis, oogenesis, and the impact of these translocations. So basically, the point to remember is that even for this couple who already have infertility, there also it's not necessary that all embryos are going to be aneuploid, all their babies will be abnormal. There is a very good chance that they will have a healthy baby.
I had an experience with 4 cases, madam, which you also know. Out of 4 cases, one patient had previous failure with own gametes, wife egg and husband sperm. But when they came to us, she had low variant reserve. So we went for a donor egg and husband sperm. In that combination, they got 2 embryos which are transferable. So we went ahead. The other 3 patients who had self gametes, one patient had 8 embryos and one patient had 6, which are all non-transferable. Like you said, out of 16, only 2 can be normal. So those 2 patients, I think the combination of their genes is resulting in more of, non-transferable embryos. Can I understand, ma'am? Because when the male is going for a donor egg, he had, transferable embryos.
Yeah, so here, no, it's not really genes, but what I was trying to say, Kina, depending on which chromosomes are involved in translocation, the size of the translocated segment, and how those chromosomes behave during meiosis. So basically, what happens is that due to this translocation, during meiosis, these chromosomes behave in an abnormal manner, and then they go to the gametes in different combinations, and so these combinations can kind of vary depending on the size of the translocation. So how many times the normal embryo gets formed, how many times an abnormal embryo gets formed can vary depending on the patient to patient, translocation to translocation. So that's why some patients will have mostly or recurrent aneuploid embryos. Some will have more possibility of the alternate segregation happening and normal embryos. So, so these figures, what are written here, are an average basically. But for a particular case, there may be differences. That
Madam, 46XY T510 Q13.3 Q22.2 was a report for whom he went for a donor oocyte and his sperm. It was a euploid balanced translocation for which they said, we can proceed.
Yeah. So that's what. So that is what I was mentioning. So the 2 gametes which are normal can have either the balanced translocation like the parent, or could be the normal chromosome completely. None of the translocated chromosomes go to that gamete. So these some different, and that's what this 16 different combinations happen during meiosis of these 2 chromosomes which are translocated. And that is what gives rise to the, some normal balanced embryos, some embryos which will be unbalanced.
So do you advise him to go for a donor egg, ma'am? I'm just thinking in a different perspective.
donor egg, he is the translocation carrier, no? So donor egg does not have any implication. But suppose this person, if you kind of use his sperm every time, and every time you do PGT-SR, and you are finding that every time aneuploid embryos only are happening. So that means that probably this translocation is mostly giving abnormal gametes and less commonly giving normal. So that patient can be offered a donor sperm.
Got it.
So it may vary from patient to patient, translocation to translocation. There can be variability. So these are average figures, what we have displayed here. But it is important to remember these average figures. Why? Because here we are coming from the perspective of a couple who already has infertility. But very often these couples get the karyotype gets done for some other reason. Then we find this translocation. So what we want to kind of say is not every case would need IVF and PGT-SR. Some patients may even naturally conceive. Some patient will not even abort. They will probably just go on to have a healthy baby. Some may not even get recognized that they have a translocation ever in their life. So it depends from family to family. So it's not mandatory to do a PGT-SR for all translocation carriers. And that being said, there would also be that extreme case who will not even benefit by PGT-SR, because they every time only aneuploid embryos are getting formed, and that patient may even need a donor, gamete. So there can be a lot of variability in the outcomes even within these translocation carriers, which again we have to see depending on their history, previous pregnancies, and then we have to take those decisions. So we'll go to next slide, Dr. Shankar. Yeah, so what, again, this case, again, we, of course, already subfertility is there. So they may be, of course, more keen. They've already undergone IVF. So they would be, of course, the best option for them would be to go for IVF and PGT-SR. But suppose there was a younger couple and then you found out the translocation due to some other reason. Let's say just did family screening and found out. So that couple, they need not directly jump to IVF and PGT-SR. So they can also be allowed to conceive naturally. And then in that case, we would advise them to go for prenatal testing to make sure that the fetus is really balanced and does not have any imbalance arising from the translocation. Whereas if you already have a couple who has infertility, then you found the translocation, or a couple who is having repeated losses, let's say 4 or 5 losses, and you found the translocation, age is on the higher side, very anxious, those couples you can directly be taken up for an IVF with PGT-SR, because that would kind of improve their pregnancy rate. And the last point what we already discussed, still if every time you are having poor outcome, then probably they can go for even a donor gamete. So Shankar, we'll continue.
Yes. They have 2 more embryos. They underwent a PGT for the 2 embryos. Both embryos found to be euploid.
So, madam, after transferring these euploid blastocysts, do we still need to reconfirm with any prenatal testing?
So again, this is very important. So ideally, all PGTs need to be confirmed by prenatal testing, but I know this is not, happening in the sense that there is a lot of, because for patients also, very often they're very precious pregnancies and they don't want to do any invasive testing. And sometimes it's also because the guiding obstetricians who are taking care are also themselves apprehensive about, referring the patient for invasive testing. But we need to remember that all PGT can have errors. So in fact, in translocation carriers, as we were discussing earlier, so PGT uses NGS. NGS can detect only a certain size of the deletion duplication. Smaller deletion duplications may not be picked up. So sometimes even the embryos which are looking euploid apparently on PGT may actually have some, at the breakpoints of those translocations, some new deletion duplication may have arisen. So those we still need to look. So for that reason, we would really still want to do prenatal testing, even if you have transferred euploid embryos after doing a PGT-SR. So
madam, do you suggest a PGT-A for PGT-SR euploid?
So again, now because NGS is getting used for doing PGT-SR, so A also automatically comes in that. So
That
the
I
same,
wanted everyone to
yes.
have
So
a message.
because as compared to the older technique where fish was being used, where only those specific translocated breakpoints were, the segments were getting picked up. Now we use NGS for PGT-SR. So that automatically looks at even the other chromosomes. So next slide.
They have single embryo transfer with frozen euploid embryo. They did not undergo prenatal testing. However, they have a healthy male child who is right now 2.5-year-old.
Did we do a karyotyping for the child, ma'am?
No, they never came back to us. So this is what usually happens, as I say, we always tell them come back for prenatal testing, come later. But then I think once they, get a
Not
baby, they
prenatal,
are
at
happy.
least. If not prenatal, at least if the child can be
Yeah, they
tested.
can bring it. Yeah, mostly, it's like they are after all that, journey. Once they have a healthy baby, I'm sure they don't want to come back to a geneticist. We mostly
Yeah.
give, scare them and give them bad news, I think.
Here in this
But
case,
we started testing the children, madam. For
no,
such.
if the PGT is showing euploid embryo and single transfer, do we need to do for the baby later?
No, in the sense, not as a protocol, prenatal testing we still should do.
Yeah,
But once the baby is born, if the baby is clinically healthy, so again, by 2.5 years, we'll come to know, if a baby has some abnormality related to those chromosomal translocations and all, that baby by this time will show developmental delay or some malformation or something. So they'll come to kind of, clinical attention. So there is no such protocol saying that we need to test the baby once it's born. They can be clinically followed up. And if any concern is there, then maybe we can do the testing.
So can I add a point here, madam?
Yes, Dr.
Why is
Sapni.
it that we have to do a coriolis or amniocentesis? Why should we do a prenatal testing? The reason is these errors are meiotic errors. So meiotic errors are happening at the oocyte and sperm level, at the embryo level, right? After that, there is mitosis as well. So you can have mitotic errors, and a couple may have a problem later on, and then they will come back and ask us, why is it that you told me that I had a normal embryo and I'm now having some problem with the child? Purnima, does that answer your question?
I think, 200%. Yes, makes sense, madam.
And also because we are looking at the placental cells. So there is 1% discordancy between placental cells and ICM. We are testing only the placental cells. The trophectoderm ultimately forms the placenta. Right?
Yes.
That also is there. So, and then there are a lot of errors that we can, not lot of errors, but there are errors known. There are problems also in PGT. So that's why it is always safer to test.
Oh.
At least you can counsel and leave them there.
Yeah.
You've done your job.
No, and one more thing which we also need to remember is that prenatal testing, there is a lot of apprehension about the miscarriage, but actually the miscarriage rate is somewhere around 1 in 1,000 now, as per available recent literature, and it is same for CVS and amniocentesis.
So, do you advise invasive or non-invasive here?
Invasive. In
Invasive.
PGT-SR, invasive. But
Invasive.
suppose you did PGT-A for, some indications what were
NIPT.
discussed. There we can advise for NIPT. There is no
That's
indication.
what, here in this case, we can go for NIPT, right?
No. Not in this case. This case, we should do invasive testing because this is translocation related. Some small chromosome segments will get imbalanced in the baby, in the embryo. So those will not even get picked up in NIPT. So here we need to do invasive
PGT-M
testing.
also, it is mandatory that we do invasive testing and confirm it.
Yes. So, Dr. Shankar, please summarize. Yes.
Parental karyotyping is essential in infertility evaluation. PGT-SR may be offered in couple with balanced reciprocal translocation. And finally, prenatal confirmation by amniocentesis is recommended. Thank you.
Thank you.
Thank you, Dr. Kavya.
Thank you, madam.
Really overshooting time. We'll quickly go to the fourth case. Dr. Soumya?
Yes, ma'am.
I think Monica, you want to introduce Dr. Sapna?
Yes, I'll do that shortly.
Yes.
So thank you for the now proceeding to the session 4, examining a highly sensitive and critical scenario, a child with genetic disease and the role of PGT. So we have Dr. Sapna Srinivas, who's having experience of more than 25 years. She's globally trained people. She brings an unparalleled depth in reproductive medicine and embryology. As an IVF lab director at Mamta Fertility Hospital, as an expert member of State Art and Surrogacy Board, she has played a pivotal role in shaping IVF practices in India, and her remarkable contributions include 18,000 plus ART cycles and birth of 10,000 plus babies. Over to you, ma'am. And we would also like to announce that Dr. Soumya is presenting this case. She's a medical genetics resident at the NIMS Hospital and NIMS Institute. And now I give it to Dr. Soumya for the next case. Thank you.
Good evening, everyone. I would like to take you through a case scenario where we would like to understand about the importance of PGT-M in a previous child with genetic disease. So here there is a family where the wife is 28 years old and the husband is 33 years old, who are consanguineously married, and they have a history of unfortunate demise of their female child at 4 years of age, which is followed by a period of infertility. And now we are going for working up of this case. So the proband has a normal antenatal period and has a smooth perinatal transition. The proband is apparently well and attained all age-appropriate milestones till 11 months of age. And after 11 months of age, she never attained any milestones and she never attained independent walking and standing. And at 18 months of age, whatever she has achieved previously also, she has lost. That means there is a regression of the previously attained milestones. And the child was also not gaining adequate height and weight as per age. So she was having a history of failure to thrive. And the baby was also having involuntary movements. And finally, she passed away because of seizures at around 4 years of age. So she is the child, and because she had all of these symptoms, we worked up the child, and the blood work was totally unremarkable. And ENMG showed axonal neuropathy. And because the child was having a history of seizures, EEG was done, and it was found to be abnormal. Because of the developmental delay, regression, and seizures, MRI brain was offered, and it showed hyperintensities in cerebral peduncles, thalami, midbrain, pons, and cerebellar regions. And BERA was done; it was normal. Serum ammonia was normal, and serum lactate was not done. So with these history.
Okay, so Dr. Sapna, so just before we start the discussion, the webinar actually is supposed to end at 10 o'clock. So the platform will shut down. So we'll keep it short. We have already discussed a lot of aspects, I think, already while we are going through. So I think here I just want to ask probably just one question, because Dr. Sapna, very often these couples come to us, and more often I think they would be coming to you. Somebody tells them that, just go for IVF. It will, take care of your problem. So is IVF the actual solution for this scenario? Just doing an IVF with their gametes.
Right. So first of all, it's an affected child in a young couple, and they're consanguineous. So we are already, when the couple comes to us, the first thing you do is reassure the couple that yes, we can help you. Second thing is, yes, IVF is an option with PGT-M, because most likely we are looking at a scenario where there is a single gene aneuploidy, a single gene defect. So a genetic defect requires a detailed history. And because this child was alive for 4 years, obviously this couple, because of the history that you're giving about the child, must have gone for some molecular diagnostic testing. So it's important to elicit all those reports so that we get a clue as to what is the problem in question. There is neuronal and muscular degeneration happening, and those T2 intensities and all that showing that there is probably a myopathy, myelopathy going on, a demyelination kind of a thing, an inflammation in the brain. And so, yes, I will not, as an IVF person, label this until we get a particular, the defect in question. So I will elucidate the family history. And this is how I would counsel the couple that, yes, first of all, I would like to do a complete examination, a thorough history. Try to get the child's reports if there is a molecular diagnosis report. Do a pelvic ultrasound. Make sure that the woman is normal. Check her ovarian reserve, at least do an antral follicular count. Ask for a semen testing. And in the first counseling, the options that we will say is that we are going to work with the multidisciplinary team. We are going to do the IVF part. There is a genetic team that is going to look at what is this disease and how we can help you to, overcome this problem and make sure that you have a healthy child. And we will also say that once your fertility reports come normal, so there is IVF PGT-M, which is recommended in this case as per all guidelines. There are more than 5,000, known genetic mutations which cause pathogenic and likely pathogenic diseases known. So it is recommended. But yes, if the fertility reports come normal and you are willing to opt for a normal pregnancy, you can still try, going for a prenatal testing, but understanding that, yes, low cost, but understanding that the geneticist will first review your reports, the baby's reports, ask for molecular diagnostic tests, find out what is the, the gene mutation in question, and give you a probability. Is it autosomal dominant, 50%? Is it recessive, 20%? Is it X-linked dominant, recessive, whatever? Give you a specific diagnosis as to this is the problem and this is how every risk for every pregnancy is going to be. And once you have understood that, then if the fertility reports come normal, you want to take that chance, you can still go for a prenatal testing. That is one option. I wouldn't recommend it. I would definitely ask for a IVF PGT-M.
So I think the important point one, of course, what we get, so we have to move a little faster. So Soumya, you just go to the next slide, please, is the fact that we need to go to the next slide, that we need to do workup of the affected child. And because this is looking like more like a single gene disorder, some metabolic condition. So here we would be doing a certain set of tests. So as geneticists, we have done a exome sequencing test for this baby and we have found the mutation. So as now, we'll go to next slide. Dr. Sapna has mentioned. So first we need to know the diagnosis. On the basis of that, we tell the recurrence risk, we tell the options. Go to next slide, Soumya. So what we have realized here that this is a single gene disorder. It's an autosomal recessive disorder. So chance of it happening again is 25%. As Dr. Sapna has reiterated that after the fertility workup, if as such the couple does not have any problem in conceiving, so they basically also have the option of going for a normal, spontaneous conception and doing a prenatal testing. The caveat here being, of course, that if it is an affected pregnancy, they will have to terminate it, which has its own associated connotations for psychological and other aspects. So the other option becomes the IVF PGT-M. Again, as a geneticist, we don't recommend this as the first tier at this point of time, because the risk of the possibility of having a healthy baby is 75%. So even prenatal testing with a spontaneous conception is an equally good option for a fertile couple, provided there is no other option, no other concerns. But I think in this case, actually, because of additional concerns, so as this couple was consanguineous, we'll go to next slide. Dr. Sapna, I'll skip some things so that, we can kind of maintain
whatever you want, madam.
Because Dr. Sangeeta needs, we need to get she also needs to finish. We need to close by 10. So now because couple are consanguineous, so in this situation, we also offer what is called as expanded carrier screening. Soumya, can you just show that? Yeah. So here we, what we found in the child, this mutation SERF1, which child was homozygous, that is both the copies of the gene were mutated, and as expected, the parents are both heterozygous carrier of this mutation. So this is what we expect. Parents are carrier, that baby got the mutation from both of them, baby is affected. This is autosomal recessive. Chance of it happening again is 25%. But what is interesting is that in this test, we also find that they are also carrier of BRCA2 mutation, both of them. And this can cause both autosomal dominant disease, which is a adult onset hereditary breast ovarian cancer condition. And this, if both partners give the mutation and baby becomes homozygous, baby will develop a more severe genetic condition, that is Fanconi anemia, which is a childhood onset condition causing bone marrow failure. So now there are two things here. So next slide, Soumya. Next slide. Yeah, so again, I think I'll skip this, most of it. I'll just want to
Ma'am, just to
say,
interrupt
yes,
you,
yes, yes,
probably,
Monica.
yeah, probably the platform will not shut down because even if you overshoot, it will continue. So you can,
Are you sure about that, Monica?
Ma'am, 99.9% I read on the internet. 0.1%, I'm not sure.
Okay,
Yeah.
okay. No, at least I'll, kind of just some things I will tell in brief, then Dr. Sapna can take her part a little bit more in detail. So our society actually says that we should offer certain carrier screening to everybody. So even if they are going for IVF or spontaneous conception, next slide, Soumya, we offer carrier screening for thalassemia and SMA to every couple, because these are the most common autosomal recessive diseases in India. But like was done in this couple, expanded carrier screening using NGS, we offer in certain scenarios only. So one of that scenario is consanguineous families like this couple. And then there are certain other scenarios. So next slide, Soumya, next slide. Yeah. So, yeah, so here now what we are getting is that, if we, so these are all calculations which we do, probability based calculations, to try to understand that what is the possibility that this baby will not get either the SERF1 mutation or the BRCA mutation in the homozygous form, where it will cause Fanconi anemia, or heterozygous form where it will cause hereditary breast cancer. So after doing all that probability, what we find is actually that the chance that they will have a healthy baby is only 18.75% in every conception. So actually now this case becomes, what Dr. Sapna is saying from beginning, I will offer IVF PGTM. Now, I will also say that yes, this is the ideal option for this couple, because the risk is too high that the baby will have one or the other condition. So then it's best to select the embryo which doesn't have any mutations. Or, if that is also, if you're finding repeatedly embryos are having one or the other mutation, then the other option is to go for a donor gamete, at least for one partner. So next slide. I think this important question I want to now ask Dr. Sapna. So, because here some condition like SERF1, that mitochondrial, or the Fanconi anemia, we know that they are severe condition, childhood onset, lead to significant morbidity, mortality. But things like BRCA2 mutation, which, causes a adult onset cancer condition, and not everybody with the mutation will develop the cancer. Only 60% people actually develop cancer, even if they have the mutation.
Right.
So then do couple really want to, couple who do have these mutation, do they want to do PGT for such adult onset conditions? Which have some treatment, some surveillance, some intervention available. So what is your experience and what do you suggest for such couples?
Okay. So first of all, ma'am, the case has changed. It has now become even more complicated, because any BRCA 1 or 2, 1 is more dangerous, 2 is slightly better. Both BRCAs, what do? They are maintaining the telomere length and they are repairing double-stranded DNA breaks. So, ma'am, I can't see you, but yeah. So they're repairing double-stranded DNA breaks. So that is the reason when there is a mutation in a BRCA1 or 2, as a fertility specialist, the first thing I must think of is this woman, the couple, they're young. But she's 28. She already has started having infertility. That's what Kavya mentioned. So it is known that because of BRCA mutations, because they are not able to repair the DNA breaks, and the oocyte is arrested in meiosis for 28 years. And it's only going to complete meiosis now in this follicular cycle, right? So it is known that there is oogenesis problems. It is known that these women do not respond well to FSH stimulation. It is known that they have a shorter fertility window. It is known and documented that they have lower AMHs compared to age controls. Okay, and now that is one part in terms of fertility assessment. So for me, as you know, an IVF specialist doing PGT, and in cases of M, I've seen two cases, madam. One was a 29-year-old girl referred from Indo-American. She's 29. She's a BRCA mutation. She has a 3.2 centimeter tumor. So it starts as early as 35. So, but this was shocking. She was very young, 3.5 centimeter tumor. Her nodes are affected, and you know she was sent for fertility assessment because that short window that they give you to at least do a letrozole or a gonadotropin cycle and try to get some embryos for her, because she was only 1 year married. And she's been trying for 1 year and she never conceived, but of course this changed the scenario. So when we looked at her AFC and AMH, very low. We attempted to stimulate, she didn't respond. Unfortunately, we talked about donor egg and had to send her back. And this is a 29-year-old girl with a BRCA mutation. Now, there is another scenario where there is a young girl who is an IT professional. Grandmother died because of breast cancer. A lot of morbidity in the family. Grandmother's sister had breast cancer. They had a BRCA1 mutation in that family. Mother had breast cancer. Mother is alive. She came, got her genetic testing with the report with BRCA1, and she said, I want to stop this here. I don't want this gene to continue into my, the offspring. What can you do? So she responded very well. She was a BRCA1 mutation. So that's another extreme scenario. She responded very well. We gave her stimulation. During stimulation, madam, you must remember that we want at least 10 to 12 oocytes so that we get 5 to 6 blastocysts for, PGT, especially M. Remember that M, we are giving them very, very little bit of DNA. So there is a lot of, there is allele dropouts, there is contamination. There could be so many things that can happen. So, and we want this embryo to be tested for two things. One is SUR, SURF gene, and then also the BRCA here. But for this patient, we must remember as fertility people that we want to stimulate and get at least a fair number of blastocysts for, testing. And we tested, 2 embryos were normal. She went on and she has these embryos now frozen. One embryo is frozen for the future fertility. If at all, she's intelligent, if she goes for a salpingo-oophorectomy, which is recommended for these patients, because they will develop, 40% of them develop ovarian cancers. 70% develop breast cancers. They have pancreatic cancers. They have melanomas. So, as a fertility specialist, for indicated cases like this, where there is a family history, there is a nice penetrance going on, and you can see that she's a BRCA1, I will help her. I want to help her. But on the other hand, we must always remember that these BRCA mutations are repairing DNA. The BRCA's role is to repair DNA, and any mutation, these repair mechanisms are gone. And that is why oogenesis and spermatogenesis are affected. In this particular case, madam, both are carriers, both are heterozygous. So 50% of their gametes will carry that mutation. And now we have this complex SURF1 also, coming in. So the amount of embryos that I'm going to get as normal, is very
so
less.
Yeah, so I understand your perspective.
One more thing I want to add, madam, is when you do a case like this, first of all, we need to do a preclinical setting with the geneticist. Preclinical test to identify those probes. Once you get those probes, you need to do a PGT-A on all the embryos first. Once the euploidy, aneuploidy, and mosaic status is known, we only pick the euploid and the low mosaics. Low mosaics are any embryo less than 48 to 50% of cells being abnormal. So low mosaics are picked up, and in that mosaic and in that normal embryo, then you do a PGT-M. There's no point in doing a PGT-M on an aneuploid embryo because it's not going to give you a pregnancy.
Yeah, so we can
in terms
see,
of BRCA, yes. Yeah. But in terms of asking the family to come and for testing, to find out whether the penetrance is high, it's not easy, madam. I have never seen any family member come in and report for a genetic testing. Very rare. And generally, couples do not like to disclose these things also to the family. And that is the sad part, because if the
That's true.
if they at least tell the family members, the other members can test and prevent breast cancer, ovarian cancer, and other cancers later on.
Yes.
So, yes,
Okay.
madam.
Absolutely taken all your points. So there's so much of complexity here. And then, of course, I think we'll skip this part. So, of course, PGTM needs to be done. So, again, there may be some differences of opinion, but basically PGTM, it's not like, for all scenarios and upfront, we need to do this, because we need to understand also that IVF per se and biopsy per se also has its own risk. So, but certain scenarios, of course, like this couple is in a way an ideal couple, and certain other scenarios we would offer. So I think we'll stop here, Soumya. Yeah, we can.
Thank you so much for having me, madam.
Yes. Thank you,
Thanks
Dr.
a lot.
Sapna, and thank you for all your points. I think we'll quickly go to Dr. Sangeeta. I mean, she's been waiting. Don't want, that we are not able to listen to her. Dr. Sangeeta, you there, please?
Yes, ma'am. Yes, ma'am. I'm
Yes,
here
yes.
only.
I'm sorry we are holding you on a short.
No, ma'am. It's okay, ma'am. I understand.
Yes.
But that was a good discussion, which was much needed.
Yeah, that's true. So I think Dr. Sujata, I'll just introduce ma'am. Dr. Sujata, are you there? So Dr. Sujata is professor of Obs and Gynae at Modern Government Maternity Hospital, MGMH, Hyderabad. Madam, are you there, Dr. Sujata? Sure, she had joined, I think. Not sure whether she's there. Okay, we'll go ahead. Monica, please unshare your slides. Sangeet, please start.
Yes, ma'am. Yes, ma'am.
So, Dr. Sangeeta, I'll introduce you also. So, yeah, you are one of our, younger dynamic geneticists. You've done your DNB from Gangaram Hospital, and you also have an obs-gynae background as your basic specialty. So, working at present in Chandigarh, and probably you are one of very few medical geneticists who are per se working in an IVF center. That's why I wanted you to be here.
Thank you so much, ma'am. So, shall I start, ma'am?
Yes, please.
Welcome, doctor. I'm stopping to share. Thank you.
Yeah, sure. So I will quickly recapitulate what we have discussed till now in the session 2. I will not take much of the time. So we have already known that what type of PGTs we have. PGT is the genetic testing of the embryos before implantation. So PGT-A, PGT-M, PGT-R we have been discussing, and I don't need to explain it all. So PGT-HLA is one thing which can be done along with the PGT-M, or maybe done in isolation in acquired some hematological conditions, or maybe some carcinomas, where embryo has to be matched with the affected sibling, so that it can act as a bone marrow donor for the affected sibling, and parents can have both the children in normal condition, and they can have healthy babies. And PGT exclusion is one category of PGT where it is done mostly in adult onset neurodegenerative disorders like Huntington disease, where affection is late in the later age, by the 40s, 50s, and parents, one of the partner has family history of the condition, and they don't want to know their own status, because of that will cause anxiety, and they want their children to be free of that disorder. In exclusion testing, we particularly do that PGT. I have one case also where we started doing that, but couple then, again backed out. So teamwork, PGT is totally a teamwork. Geneticist, genetic counselor, IVF counselor, genetic lab, embryologist, and ART specialist, of course, they have a major role in PGT. So this is the overview of the PGT procedure that has been given very beautifully by Ashray in 2020. So all the PGT procedures, PGT-M, PGT-SR, PGT-A, first of all, inclusion, exclusion has to be done by the geneticist, because they know what to do and which report has to be, relied upon, and then they can proceed further or not. So in PGT-SR and PGT-A, there is no much investigation prior to the PGT. We only advise the karyotype, and most of the time PGT-SR are the balanced translocation carriers. And in PGT-A, we usually do the karyotype before getting the PGT-A done, as Dr. Kavya already emphasized on doing this karyotype. Then the counseling is the mainstay of the PGT. So to be done by IVF specialist, to be done by a geneticist, certified geneticist who can handle such counselings, because there are lot many points and lot many queries by the patient. So we have to cover each and everything. I am doing it since last, I think, 7 or 8 years, and this is actually a very good experience. So biopsy, then that is followed by the IVF stimulation, followed by the biopsy, and then the genetic testing, and then post test counseling. Only PGT-M differ in all other approaches, like pre-PGT workup is required in PGT-M, not in PGT-SR and PGT-A. In workup, parental as well as affected persons or affected child samples, along with their maybe extended family members, depending upon what gene we are looking upon or what we are going to test. So it depends, but pre-PGT workup is must in PGT-M, and that has to be done very carefully. So I will start with PGT-M. It is currently present for more than 500 single gene disorders. Commonest examples are thalassemia, cystic fibrosis, spinal muscular atrophy, myotonic dystrophy, Huntington disease, tuberculosis, Fragile X syndrome, and hereditary cancers in adult onset disorders. That is also in very much demand. Patient ask for the PGT on them because they don't want their children to suffer later on with the cancers, or maybe the susceptibility to the cancers, and throughout surveillance of that becomes very messy for the patients as well as for children. So PGT-M when to do, when good or average ovarian reserve, that is the major point in deciding for the PGT-M. Even patient whenever comes to us, we always before giving the reproductive options and before advising them PGT-M, we always check their ovarian reserve by doing the AMH and average follicular count, so that we have just an idea, because we can prescribe the PGT-M or not, that depends upon ovarian reserve only. And if average ovarian reserve is there, then we ask the patient that we may have to go for the embryo pooling, because in one cycle we might not be getting the enough number of embryos. So that is very, very important. Certain genetic diagnosis with known pathogenic or likely pathogenic germ-line variations, that is also most important criteria, because I have seen many reports where the PGT was carried out on VOUS only, and we can't counsel the patient that we have done the PGT or over the VOUS and later on your child will be totally healthy. We can't promise that. No contraindications to IVF. That is a major point, because sometimes patient may be having some medical problems like pulmonary hypertension or Epstein anomaly, where mothers are, not subjected to IVF. So that is also to be taken care of. Consanguineous couples who are carriers of multiple gene, as we already presented this case, but this also again has to be cautiously used in consanguineous couples, because sometimes there can be risk of misdiagnosis, because both the parents can be having some regions of homozygosity, or maybe sharing of the multiple markers together, that can also lead to sometime misdiagnosis, and we have to be very careful for before counseling or before taking everything into account. When HLA typing is required concurrently for HSCT, hematopoietic stem cell transplantation of the affected sibling, I have already discussed it. When not to be done, advanced female age, uncertain diagnosis, I already explained, and uncertain mode of inheritance, we are not able to find out whether the particular gene is causing particular problem. Multifactorial genetic disorders like diabetes, hypertension, patient keep asking us whether it is possible to do it. At present, I don't know. Maybe we are getting the genes, particular genes in next 10 years. Maybe we may be able to do for everything. Contraindications for IVF due to medical reasons, I have already told, and female partner affected with serious autosomal dominant and X-linked disorders. Maybe she is not amenable to go for PGT. So in every case, geneticist consultation is must, and it can be given as an option, not the primarily to be prescribed. For cytoplasmic mitochondrial disorders, we have to be very cautious, telling the patient that, okay, mitochondrial disorder. I'm not talking about the nuclear encoded mitochondrial genes. I'm talking about cytoplasmic only, like Late disease, MELAS, and LHON. So in certain mitochondrial disorders, if we are able to, find out an embryo which has a mutation load less than 18%, we may be able to transfer the embryos, but that embryo is totally not representative of the full, human. So that is very, very difficult counseling, and we must counsel the patient that we still are not sure that we may be having the problem or not. So that is impending, that is a confounding factor for mitochondrial disorders. Repeat disorders, yes, we have to be very cautious because direct testing is mostly impossible on, small amount of fetal DNA, embryonic DNA. So Huntington disease, Fragile X, these are the triplet repeat disorders. De novo mutations where only one child is affected and we don't have any other person for the linkage analysis, that can also lead to sometimes misdiagnosis. We had one case in our clinic where we had to refuse the patient because we couldn't find the particular markers for linkage in the pre-PGT workup. And advantages of and limitations of PGT-M. So advantage we have already discussed. We can prevent the transmission of genetic disorders and their morbid complications. No mental trauma related to the termination after prenatal diagnosis. PGT-HLA is the added advantage. Limitations. It's an always an IVF, even in the spontaneously conceiving couples. Cost. Cost is major confounding factor because at present, even the Indian labs, they have lot of cost for PGT. So cost will definitely come down in next 4 or 5 years because it is getting advanced now. IVF success is again dependent upon the clinical profile of the patient, not only on the what mutation we are testing. Confirmation of the results has to be done by the invasive testing as per the guidelines, whatever they say. PGT-SR. Now I'm discussing the PGT-SR. One of the partner is carrier of reciprocal or Robertsonian translocation or inversion. That is the indication. When not to do. Poor ovarian reserve, contraindications to IVF, we have already discussed. Carriers of translocation of chromosome 21, because we are, mostly seeing the cases in Robertsonian translocations. We are dealing with mostly 14, 21, 13, 14, 13, 15. These are the translocations we are getting. We are aware of the 21:21 translocation where there is 100% risk of Down syndrome in the child. So we don't recommend in these cases PGT-SR. That is a totally a waste. And I also had one case, I think 2 to 3 years back, where patient had recurrent pregnancy losses and no genetic testing was carried out. And then when the karyotype was done, so father was, male partner was found to have this translocation. Then PGT, we did not give the option of PGT-SR. They directly went for donor sperm because we don't have any other choice. So as an option, PGT-SR can be kept. Dr. Shagun very well mentioned that if couple with no personal or family history of RPL and detected to have carrier status incidentally, they don't have any bad obstetric history, RIF or anything, infertility. So we can definitely give them the option of spontaneous conception followed by prenatal diagnosis. So what are the advantages and limitations? Implantation of the balanced or normal embryo that prevents the RIF and RPL. Low risk of transmission, termination after, prenatal diagnosis if they are conceiving spontaneously. Limitations, we have already discussed most of the limitations in other PGTs. Risk, yes, risk is transfer of apparently balanced embryos. So we think that they are balanced, but sometimes there can be some cryptic deletions or duplications. Dr. Shagun also mentioned. So that has to be taken care of, and sometimes we have to carry out the FISH during prenatal diagnosis. Risk of UPD, uniparental disomy, especially in Robertsonian translocations. No normal or balanced embryo. Sometimes we are left in a soup, especially after doing the PGT-SR for reciprocal translocations. I have had at least 2 or 3 cases where we couldn't find even a single, normal embryo where female partner was the carrier. So most of the time, female partners have poor prognosis. Reciprocal translocations have poor prognosis. So sometimes they can be unrelated aneuploidies due to interchromosomal effects, not only because of the those chromosomes which are involved in the translocation. There could be unrelated aneuploidies as well, which is well mentioned in the literature as well. And genetic counseling in every case of PGT-SR is must. Chromosome, because results depend upon the chromosomal segregation pattern, which depends upon the type of translocation, chromosomes involved, position of the breakpoints, and the sex of the carrier. I've already mentioned. And the chromosomes where acrocentric chromosomes like 13, 14, 15, and 21, 22, if these are involved, most of the time there can be bad prognosis. And risk of unbalanced gametes, they can range from 19% to 91%. Although we always counsel that there are 50% chances, but Dr. Shagun also mentioned that every cases are different. So that can lead to RPL stillbirth. So one size doesn't fit all. So that has to be, always keep in mind. Because I have, lot of experience with PGT-SR now, so I can definitely say that one size doesn't fit all. So this is the aneuploidy screening. So aneuploidy screening, in March 2023, so International Society of Reproductive Genetics and Genomics, they released the guidelines. They advised PGTA only and only for four conditions: advanced maternal age, 38 years old and above, or more recurrent miscarriages between 4th and 12th gestational weeks, 3 or more RIF after transfer of cleavage stage embryo or blastocyst with a high morphological score, and unexplained severe teratozoospermia with more than 96% of the sperms exhibiting abnormal morphology caused by defect in the head, midface, or tail. These are the 4 indications we have to, keep in mind. When not to do: selection of non-disease traits such as appearance, height, and skin color, because we are not producing designer babies. Other circumstances where PGT is restricted under local laws, regulations, or ethics. In some countries, PGT is not allowed as well. 47XYY, 47XXX karyotype of the, if one of the partner, they have a low risk of transmission of aneuploidies. Therefore, PGT is usually not recommended. But I have seen many centers are doing for these as well. Common chromosomal polymorphisms such as 1q H plus, 9q H plus, inversion 9, and inversion Y, and YQ H plus. Usually PGT is not for them, because they can be having normal outcomes as well. So advantages are, you all know, that increase in plantation, decrease in abortion rate, less abnormal pregnancies. We can plan single embryo transfer if you have found the euploid embryo, decrease time to pregnancy, and increase the cost effectiveness of the IVF procedure. But limitations are high expectations of the patients, because patient, if they are paying too much for the IVF as well as PGTA, they will always expect that we are going to have absolutely normal baby. So we have to counsel the patient that we are only checking the chromosomal abnormalities, single gene disorders, and not looking into, and environmental factors definitely we can't check. So we have to make sure that they are not 100%, expecting that we having a normal child. Mosaic result, that is the most, limiting, most confounding factor in PGTA. And I am getting, at least 2 or 3 or 4 or 5 reports in a month. Cost again, and no euploid embryo again, there can be, because in our case also that was different, although So mosaicism, I will, I would like to emphasize with this one slide. Mosaic embryos contain a mix of euploid and aneuploid cells. Incidence is 5 to 20%, but can be up to 40%. And what is the source? Improper embryo biopsy techniques or apoptotic or dead cells in the biopsy. So we have to be very careful during the biopsy. And mosaic embryos, they can decrease the implantation and increase miscarriage rates as compared to euploid embryos. But as I agree with the faculty that they said that low mosaic transfer is recommended now, because there are many studies which are recommending low mosaic embryo transfers, and good results are also seen. I also have experience of low mosaic transfers, and babies are doing well. So future perspectives of PGT, non-invasive PGT, PGT-P, that is polygenic risk score after taking out, and that is currently done through NIPGT, and research is going on, maybe getting few answers. An integrated workflow where we can test simultaneously for aneuploidies, for monogenic disorders, and for unbalanced chromosomal complements. So this was the recapitulate of the whatever we have discussed. I think I did not miss anything.
Thank you, Dr. Sangeeta. This was wonderful, actually. You've covered whole of PGT and highlighted all the important aspects. So
thank you, ma'am.
Good evening, doctors. I'll be taking few minutes to share a small presentation on integrated genomic solutions of UNIGENOME across the reproductive continuum pertaining to infertility workup and pre-implantation genetic testing. Today, we discussed a fundamental shift in clinical practice. Clinicians are now entering into an era where precision genomics dictates the clinical workflow, saving a lot of time, reducing the cost, and improving patient outcomes. So before we dive into the clinical pathways, I just want to anchor who I am representing. Unipath and UNIGENOME, the Genomic and Cytogenetic Division, isn't just a lab, but it's a nationwide diagnostic infrastructure. We process over 12,000 samples every single day across 50 laboratories with the quality assurance of NABL. With a multidisciplinary team of 75 plus pathologists and geneticists and scientists, we also ensure we use high-end equipments so that we have the engine available and you can focus entirely on driving the patient care. With traditional IVF, genetics was the last resort after multiple failed cycles. Today, in the modern pathway, we integrate genomics at day one, driven by advanced maternal age, better technologies that are available, exponential reduction in the cost, and advancements in accessibility of the testing. Genomics is no longer a diagnostic test. It is also a prognostic test. Over the last decade, transitioning from a researcher to a leading the product strategy, I have realized the hard truth. The biggest hurdle to genomic adoption isn't the science, it's the misconception that it is too complex or time consuming. The right genetic test ordered in consultation with a clinical geneticist often provides the fastest route to a successful pregnancy. Now, let's dive into the genetic testing offered by UNIGENOME to identify the hidden variables in female infertility. To effectively evaluate the genetic cause of female infertility, we offer a three-step genomic workflow. At first, we establish the structural baseline using the test karyotype. When looking for balanced translocations that drive recurrent pregnancy losses or cases of mosaic Turner syndrome on unexplained infertility, our lab champions this assay with highly experienced experts in the field of cytogenetics. and fully automated iCaros Metasystems machines that allows us to detect subtle abnormalities like isodicentric chromosomes, ring chromosomes, and very complex mosaic cases as well. Second, we deploy the ovarian reserve protector, Fragile X or FMR1 screening through gold standard triple primed PCR method. This assay accurately rules out premature expansions that actively drive Fragile X associated premature ovarian insufficiency. If this comes back positive, your action plan changes. It triggers urgent, immediate genetic counseling for the risk of inheritance, fertility preservations, and also mandates cascade testing for her siblings. Finally, for the cases that continue to challenge clinicians, particularly for women with syndromic features or positive family history, we turn to ultimate diagnostic tool, whole genome sequencing through the next generation sequencing method. Often referred as idiopathic solver, whole exome sequencing identifies underlying monogenic cause that may otherwise go undiagnosed. Performed on advanced platform, NovaSeq X Plus, it offers 99% sensitivity for single nucleotide variations, greater than 90% sensitivity for copy number variations, and high accuracy for mitochondrial DNA variants as well. These reports are validated and signed by clinical geneticists at our lab. This approach particularly is valuable in addressing complex, devastating conditions such as oocyte maturation defects and empty follicle syndrome, where conventional diagnostics often fail to give an answer. It's time to pause and reflect on UNIGENOME's highly customized and specialized genetic tests for female infertility inside the Femila Precision Panel, karyotyping, Fragile X screening, and whole exome sequencing. Next, let's talk about the missing 50%, genetic testing offered by UNIGENOME for male infertility. Historically, the male partner is underdiagnosed until we hit the wall. We need to change that paradigm today with one golden rule discussed today by our faculty experts that azoospermia is a symptom, not a diagnosis. Genetics provide the actual answer. The moment that we find that the semen analysis comes back as oligospermia or azoospermia, we have to use the first line filter, a karyotype, that rapidly identifies major numerical and structural chromosomal issues, such as the Klinefelter syndrome, giving you an immediate baseline. Second, and most importantly, for non-obstructive azoospermia, you need to order the surgical decider, the Y chromosome microdeletion test that checks for the AZF region deletions. This test literally dictates your surgical pathway. If the YCMD reveals an AZF-C deletion, the literature shows that there is still a chance of retrieving a viable sperm. You can confidently proceed to the TESE surgical extraction, post-genetic counseling of the couple. However, if the test reveals an AZF-A or AZF-B deletion, the chances of retrieving sperm is virtually zero. So your clinical action is going to change. You will cancel the TESE. Finally, what happens when both karyotyping and Y chromosome microdeletion tests come out perfectly normal, and you still see an obstructive azoospermia, or you are facing idiopathic spermatogenetic failures, or you're seeing a syndromic case? That is where our unexplained frontier, that is the whole exome sequencing, comes into action to hit on the single gene defects that cause these kind of issues. Time to pause and reflect on UNIGENOME's highly specialized genetic test for male infertility under the Ando Precision Panel, that is karyotype, Y chromosome microdeletion, and whole exome sequencing. Moving on, let us discuss about the preimplantation genetic testing for aneuploidies. And I would like to focus on the biopsy bottleneck of PGTA. You work tirelessly to get a high-quality day 5 blastocyst, but if the lab uses a legacy whole genome amplification, the tiny 5 to 7 cell biopsy may get subjected to the amplification bias. It's like making a photocopy of a photocopy, and then what happens is the errors compound, leading to an amplification bias, and that may give false negative results or false positive results. To overcome this amplification bias, UNIGENOME utilizes the Malback technology. By forcing the DNA to form hairpin loops, we prevent the exponential bias, which causes the amplification bias. Malback is going back to the original master document every time you need to make a copy, ensuring that you get perfect clarity in every copy that you make. And the result is unmatched genomic uniformity and an allele dropout rate less than mere 10%. Moreover, we deploy high-resolution sequencing on NovaSeq X+. The embryonic DNA is too less. Therefore, when we sequence the DNA on NovaSeq X Plus platform, it gives us a greater resolution with double the reads per sample. So we are not just looking for whole missing chromosomes. We are able to catch tiny segmental errors that drive recurrent implantation failures. And we can also pick up good level of mosaicisms. It actually allows us to virtually eliminate the no-call reports. We also ensure the clinical confidence by utilizing ChromeGo, artificial intelligence and machine learning-driven bioinformatics platform, which provides us very high CNV accuracy and complete transparency of QC matrices. We ensure that we run a blank control on every run so that when you transfer the embryo, you do it with absolute clinical confidence. I don't know, my slide is not moving. Just give me 1 minute. Yeah, hope my slides are visible. So moving on, we also wish to ensure that we use a zero friction cold chain logistics, because even the best sequencers of the world cannot save a degraded sample. We take full ownership of the logistics. We provide the kits, the SOPs, and dry ice shipments at no additional cost. We protect the genomic integrity of every cell that you send from your lab bench to our laboratory. Time to pause and reflect on UNIGENOME's highly specialized genetic test, pre-implantation genetic testing for aneuploidies. Now moving on about optimizing the endometrial environment with the FertiGuard test. So we've talked extensively about the seed, the embryo. Now we must talk about the soil and address the complexities of the endometrium. Even if you transfer a perfect NGS tested embryo, but if the endometrium is inflamed or immunologically hostile, the implantation might fail. FertiGuard is designed to stop you from transferring precious embryos into a compromised environment, just with a single straightforward endometrium biopsy in the luteal phase. So FertiGuard comes with 5-pillar comprehensive endometrial and infectious assessment designed to leave no blind spots. Firstly, as the first pillar, we do histopathology of the endometrium that allows us to address and check endometrial morphology, hormonal influence, and structural abnormalities. We also identify subtle critical issues like luteal phase defects and granulomatous inflammations, which are consistent with tuberculosis. Second pillar of FertiGuard is the chronic endometritis detection with immunohistochemistry marker CD138. We know that chronic endometritis is significantly underdiagnosed, yet it has a direct impact on the implantation failures. Using CD138 IHC, we can accurately detect the plasma cells which infiltrates the endometrial stroma, and this analysis is far superior to the routine H&E or the culture method. The third pillar of FertiGuard is the TRICE panel targeted RT-PCR for infectious chronic endometritis. Moving beyond the cultural limitations of culture failures, TRICE enables simultaneous detection of multiple pathogens, including the unculturable organisms. From mycoplasma to ureaplasma to chlamydia, we get a comprehensive infectious profile. And the advantage you get is a faster turnaround time, higher sensitivity, and precise targeted therapy, where you don't have to offer empirical antibiotics. The fourth pillar of this test is uterine NK cell assessment. By assessing the uterine NK cells, we evaluate the immune environment at the maternal-fetal interface. Abnormal levels can explain recurrent implantation failures and pregnancy loss, guiding immunomodulatory treatments. And the fifth and the final pillar of FertiGuard is the BCL6 immunohistochemistry test with H-score. So we are now looking at the silent disruptor endometriosis. It is from research, it is seen that BCL6 expression is a strong marker of progesterone resistance and poor IVF outcomes. With high sensitivity, this test detects even early or occult disease and guides the personalized medical and surgical treatments. So we have seen that Unipath offers a complete genomic continuum. We are your partner across different testing, starting from preconception carrier screening to endometrium receptivity using endometrium receptivity array, to prenatal screening with non-invasive prenatal testing and diagnostic invasive testing as well. We provide a complete, cohesive, unified diagnostic strategy. With this, I would like to end my presentation and invite you to standardize your workflows with UNIGENOME. Thank you. Thanks once again for the opportunity.